change, and in pointing to concrete ways we can begin rebuilding trust, both within organizations and between providers and patients. Thank you again for being here and online, and I look forward to our discussions. Polly, I'm going to turn this back to you.
Thank you so much, Lynn. And we didn't actually talk a lot about this topic before you came today, but you totally got it. You totally get it. And I suspect that it's because you are a clinician yourself, and people who have that lived experience get this topic pretty quickly. So before I just make a couple more comments, I also wanted to acknowledge the support of HRSA, which was one of our funders for this event, as well as two very good friends of Fitz from his kindergarten years, Peter Darrow and Jeff Cohen, who've supported the Summit series. So as Lynn said, it's impossible to recognize that in this context we're living in a situation where there's growing societal mistrust in government, mistrust in businesses, mistrust in universities, and even in our communities. In healthcare, the level of conflict and accusations was rising pre-pandemic, but clearly COVID exponentially raised the pitch, with mistrust in science, violence against health workers, and within the healthcare workforce what appeared at first to be a crisis of burnout, with its related rise in suicide rates and attrition from the field. At the Workplace Change Collaborative, a technical assistance center funded by HRSA, we were supporting 44 grantees across the country that received grants to address burnout. And you'll be hearing more from some of those grantees, as well as a summary of some of that work from Corey Feist on our second panel. We were charged with developing a national framework to understand the problem. And in contrast with some of the previous frameworks, we emphasized that in addition to burnout, there was clearly a related but distinct phenomenon of moral injury. We convened a group of experts and talked a lot about what was driving moral injury and how it was different from burnout. The central missing element from the Maslow drivers of burnout was health worker mistrust in their organizations, and the health system more broadly as well. Mistrust is directly related to the perception of betrayal by authorities, which when workers are not able to speak up, leads to moral injury. In other words, the pain of having to live with the awareness that they could not do right by their patients under these conditions. In effect, they could not honor their professional oath to do no harm and to advocate for patients and families. We posit that unless you take into account this issue of trust, that the technical fixes of EHRs or of increased access to mental health services will not be enough to take that pain away. We've since learned, thanks to a landmark randomized study conducted by Mark Linzer and his colleagues at Hennepin Health, that patient trust in clinicians declines when clinicians do not trust their organizations. This has now been proven using the gold standard of science. Moreover, they confirmed that trust is directly affected by clinicians' voice in how they provide quality of care. This is why trust is such a linchpin in healthcare. Additionally, in today's context, the polarization and misinformation further exacerbates the loss of trust for health workers, because health workers, as you all know, are part of their communities. They're not just health workers. And the fear and suspicion and uncertainty about the future is pervading this environment as well. So what we have is a vicious cycle. However, the flip side of that is that if we can figure out how to rebuild trust, which will be no small task, we will not only improve health worker well-being, but we will improve the patient outcomes, which are intrinsically linked to trust in the system. Today, we will hear about evidence regarding both the problem and potential solutions for different types of health workers and different types of settings, as well as a set of cutting-edge experiences that have not yet been adequately studied, but we hope will be in the future, that showcase different ways that organizations are approaching the challenge of rebuilding trust. Before we begin our two panels, however, we will start with the story of one physician. I'm very excited to introduce Dr. Guinevere Burke. Gwen leads our Atlantic Fellows for Health Equity program at the Mullan Institute, but I've asked her to speak to you today in her capacity as a practicing emergency medicine physician. Like many ED docs, she's seen it all, and like many healthcare workers, she has for years buried those stories of patients that did not receive the care they deserve somewhere deep inside her. So deep that I know unearthing these archives is extremely painful for her. I want to say in advance just how much we appreciate her for being willing to share her experiences, just as we appreciate so many other healthcare workers for stepping up and speaking out in ways that help those of us on the outside understand what's happening in healthcare. Gwen?
Thank you, Polly, for the introduction and for the opportunity to speak on an issue, as you mentioned, that's so close to my heart and so important to my ongoing work. As an emergency physician for the past 16 years, and as a daughter who recently lost her dad, I want to bring it a little closer. The idea of restoring health worker trust in organizations is personal and important in so many ways. My role today is to share the toll on health workers and families in the current state of distrust and impress upon you why now is a critical time to take up this issue. Feels too low. I could just hold it. Okay. Oh, that's good. Can you hear me? Yes. Excellent. Thank you. All right. So I'm pictured here on the left in the days of my early clinical training in Los Angeles. And from the very beginning of my clinical training, I was taught to introduce myself, of course, but then to apologize for the wait. Over the years, I've continued to apologize, but the scope of my apologies has expanded. One of the most memorable was my apology to a new mother under my care. She shared that she had just lost one of her triplets shortly after their birth. She came to the ER because she was struggling with depression after the baby's death and seeking help because she questioned her ability to safely care for the surviving infants at home. She had requested and was offered admission to the hospital, but returned home because insurance wouldn't pay for it, and she couldn't afford it. I'm so sorry we couldn't do more, I told her then, and I continue to tell myself now. In the days that followed, I waited for news of infanticide to make the headlines. There were no reports, and yet for years I have wondered what became of her and her newborns. After 16 years in emergency medicine, I have over 16,000 patient stories to tell, and this is just one. Another patient story, my father's, pictured here on the right, has reminded me of the many layers of complexity, of trust and distrust in our healthcare systems and organizations. After receiving a diagnosis of brain cancer, we sought care up and down the East Coast. And the only consistent outcome was a deepening sense of distrust with each encounter, although we met some really smart and caring individuals. As I reviewed the literature on trust in preparation for this summit, one statement stood out as summarizing the experience of care with my dad. That high trust in individual clinicians is not protective in the setting of institutional betrayal. It's so true. After a visit with a trusted doc, the inability to get prescriptions, the callousness or carelessness of another team member, the unexpected bills, cost of drugs, insurance refusals, unanswered phone calls, instilled a sense of distrust that no matter what the well-intentioned clinician says, the course of care was going to be dictated by the limitations of the system, not the clinical evidence or recommendations. And we carried this sense of distrust until the very end, as he was admitted to hospice and we faced the inevitable. Being in hospice was the only time in his illness that we could reliably get somebody to answer return calls, when medications were covered and sent to the house without a struggle. The system would fight us to help him live, ignoring physician orders for rehabilitation or physical therapy to help him remain active, but acted quickly to send a hospital bed and other supports for him to lay down and die. As individual clinicians, we cannot overcome these realities with our clinical knowledge or even outsized kindness and dedication. High trust in individual clinicians is not protective with institutional betrayal. Absolutely. It's true in my experience as a family member and as a doctor. And I wish that these were my own personal experiences, but they're not. I've worked in for-profit and not-for-profit institutions, government and private facilities, in small ERs with just a dozen beds, and in those with over 100 beds for the ER alone. I've worked in different states across the country and have been teaching health policy to physicians and health leaders for the past 12 years. These experiences are not mine alone. Unfortunately, they reflect broader societal and industry trends that are worsening. Here you see surveys of patient trust on the left and clinician trust on the right. During the pandemic, as mentioned, public trust in doctors declined from a high of over 70% to just 40%. And in a recent survey of healthcare workers shown on the right, less than half said they trusted their organizational leadership to do the right thing for patients. Even fewer, just over 20%, trust leadership to do the right thing for their workers. These numbers are abysmal. And while public attention, as mentioned, the news cycle, focuses on changes in our government and economy, for those of us who are struggling to provide care every day, issues of trust remain vitally important. For all those families like mine, fighting for their loved ones in ailing health systems across the country, it is everything. The weight of the stories that I carry increases each year. For some, the weight becomes too much. The data on trust for healthcare workers shows that it's closely linked to burnout and moral injury, as was mentioned. And this graphic from the Mullan Institute and their great work on moral injury is beyond the scope of this talk, but I want to highlight a few aspects that are most relevant to this discussion. Oh, it's tiny. I'll just tell you what it says. The circles on the right describe some of the features of moral injury: anger, shame, guilt, and frustration. Moral injury is the term that's increasingly used to describe what healthcare workers experience when they're forced to compromise their morals by taking part in care that is degrading when you have a duty to respect, and care that can be injurious when you have committed to heal. The framework also points to possible benefits of confronting these challenges for healthcare workers and patients, of course, but also for organizations who are struggling with high turnover and critical staff shortages. It begins to point to solutions. If you could see the graphic, I would ask you to shift your attention to the left. Perhaps online you can. While distrust and moral injury are associated with values conflict and a lack of control, as Polly pointed out, the literature shows that the opposite is also true. Efforts to align values and improve communications characterize high trust relationships in healthcare, and those can mitigate burnout and moral injury. In the past, research has largely focused on the patient-physician relationship and trust in that setting, and much less attention has been paid to building and restoring clinician trust in healthcare organizations. But it's time to shift our focus. A few trends in healthcare have powerfully impacted the urgency of the situation. According to a recent government report, the healthcare industry is more concentrated than ever, now after 30 years of steady consolidation. By one estimate, over 200 million people, representing over 90% of metropolitan statistical areas, are in markets where there is a high concentration of hospitals, physician groups, or insurers, limiting competition according to the published criteria of the Justice Department and FTC. If 90% of markets are highly concentrated, meaning there's only one or two employers, a few physician groups, and you feel that the system is failing you, failing your patients, where can you go? What can you do? This kind of market concentration and power is bad for patients. It means less competition, higher prices, and sometimes negative impacts on quality and safety. For healthcare workers, it means downward pressure on wages, less negotiating power, and a loss of voice that can fuel distrust and moral injury when patient care concerns arise. With respect to ownership, the role of corporate entities and private equity in healthcare has expanded considerably. In my own field of emergency medicine, it's estimated that 40% of ERs are now staffed by for-profit private equity firms. With increasing consolidation, corporate and private equity ownership, now almost 4 in 5 physicians across the entire country is a physician employee. Pressures to cut costs and raise revenue to create profits have been widely cited as setting up a values conflict between leadership and healthcare workers. Again, a major contributor to moral injury and distrust. Historic levels of consolidation and changes in ownership and leadership are a setup for values conflict, diminished clinician voice, and distrust, but they still don't tell the whole story. I shared before that my role today is to describe in real human terms the toll on health workers and families in the current state of distrust, and to impress upon you why now is a critical time to take up this issue. I would add that I'm here to begin a conversation. This summit is designed to dive deeper in the search to understand and develop solutions. We're not here to assign blame or point fingers. We're here to address a serious problem that is hurting our health workers and hurting our patients and families. I still begin my patient visits with an apology, but I don't stay there long. I shift to addressing the problem at hand. And although the weight of thousands of patient stories, including my dad's, remains heavy, losing someone close to you gives you a new appreciation for the time that you have. I have, and we all have, an incredible opportunity before us. The opportunity to engage with philosophers, clinicians, organizational leaders, management experts, anthropologists, and other scholars. We have the opportunity to explore how to restore trust in our healthcare organizations. I just returned to DC from a gathering of health leaders abroad. That small community of just over 100 individuals has impacted millions of lives by being willing to ask hard questions and implement solutions despite challenges and setbacks. This room and the folks online number close to 200, and I'm hopeful that this small gathering also has the potential to impact millions of lives. And I'd like to invite anyone who feels passionately about taking this work forward to join us in the conversation today, and more importantly, in taking action after this summit. I thank you for allowing me to share my patient's story and my father's story with you. Thank you for being here and for giving me hope that we can change those stories for others.
Thank you, Gwen. That was more than I had hoped for, and it was really beautiful and a real call to action. We have a couple more minutes before we start our first panel, if anybody would like to make any comments or ask any questions as we get started. Okay, if not, we can move to the first panel, and I will invite Carolyn Newhouse to chair our next panel. Thanks.
We can be okay with that. That's great. Ready? Yeah. Okay, great. Thank you, Gwen and Polly and Lynn, for your introduction and kicking us off in such an important way. The sense of urgency is really palpable, and how personal and touching this issue is, in the sense that it touches all of us as patients, as caregivers, as researchers, and especially as healthcare providers and healthcare workers in all types of roles. So I'm Carolyn Newhouse. I'm a research scholar at the Hastings Center for Bioethics, a bioethics research institute located in New York. And we have a long history of doing interdisciplinary work in the humanities, interrogating values that should guide medicine and science and technological development. And of course, trust is right at the top of how we get along in society to achieve the goals that we set for ourselves. I'm a philosopher by training, which will hopefully serve me well as moderator. I'm very glad I don't have to answer the questions I'll pose to this panel, because the questions we're asking are really hard ones. The sort of organizing framework for this panel is, what do we know about health worker trust in organizations, and how do we begin to rebuild trust in organizations? And as Gwen said, this is a hard question in part because there's not a huge body of work, of research on health worker trust in organizations. The trust literature and quantitative and qualitative research on trust has tended to focus on patient trust and patient-clinician trust. But of course, there's lots of evidence to show that trust in organizations is an important lever of that. And so, whether we're talking about health worker trust in organizations because it ultimately improves patient safety and quality and outcomes, or whether we're talking about it because it's intrinsically important on its own, I think there's lots of entry points for this conversation. And it's also hard because trust is a really fuzzy concept. And, is it a belief in an organization? Is it a feeling? Is it relational, or can it be one-sided? Is it a set of behaviors? And these are the kinds of conceptual questions that I hope we'll get to in the panel to help us set the goal, right? And we know we need lots of multi-sectoral organization and all sorts of people working together to rebuild this thing we call trust. But we've got to sort of have a good handle on what the goal is that we're all working toward together. So we've invited this panel of researchers and practitioners to say something about aspects and measures and interventions within healthcare workforce improvement, I'll just call it, that we think are related to trust. So we'll hear sort of different things that I just call that are in the stew. Moral injury, burnout on the flip side, retention, pro-social behaviors, team dynamics, worker voice and agency, that we think are all part of the solution, and thinking through together, what is the connection to this thing that we call trust that we're shooting for. So I'm going to tell you about each of our panelists, and then I won't do that again. So then you'll just get up and each give a presentation rapid fire, and we'll sit down and have a conversation. So first we have Alden. He is an assistant professor of public health policy and management at the NYU School of Global Public Health. With training in health policy and management, he conducts research on how jobs and work environments of healthcare workers can be improved to increase employee outcomes as well as organizational performance. Thank you, Alden. Then we have Lindsay Martin. Lindsay is a healthcare improvement and innovation leader dedicated to system design, improvement, and innovation. Formerly with the Institute for Healthcare Innovation, she co-founded Innovation Capital, a healthcare innovation consulting firm working with healthcare organizations around the world. Our third presenter will be Hannah Fairley. Hannah is a fourth-year emergency resident here at George Washington University. And as a resident, Dr. Fairley played a pivotal role in the formation of GW's House Staff Union, serving on both the organizing and bargaining committees. In the fall, Dr. Fairley will start her attending career at 2 emergency departments in the DC metro area. And finally, we have Joden Platt. She's an associate professor of learning health sciences at the University of Michigan Medical School and an associate professor of health management and policy in the School of Public Health. Trained in medical sociology and health policy, her research advances our understanding of what makes data-driven health trusted and the pathways for earning, achieving, and sustaining trust across stakeholders. Alden, kick us off.
Good afternoon, everyone in the room and also those online for joining us. My name is Alden, and I should first of all thank Gwen again for the very touching and also sharing a personal story. I was just thinking it's really hard to follow, kind of like Gwen, in terms of your presentation, so thank you again. I'm a healthcare management scholar, so my work really focuses on the intersection between management science, organizational behavior, and health services. And today, I'm hoping to spend a couple of minutes to talk about proactive behaviors and trust. And as Carolyn was talking about, trust is sometimes an elusive concept. It's multifaceted. It can be a belief. It can be a value. So scholars have really tried to study trust in multiple ways. Some look at trust in terms of contracts. It can be an actual legal contract. It could be seen as a social contract. Some have studied trust as in terms of external shock events. So what happens when there's an external shock event that collapses trust within the organization? And for me, I have chosen to use the lens of proactive behaviors, partially also because I identify as a positive organizational scholar. So it's the decline in trust and the mistrust, it's really worrying. And I'm hopeful that by studying what works and what's positive and what's facilitating trust, we can get an inkling of what might be helpful. So just to give a brief definition, proactive behaviors are really discretionary behaviors that are self-starting, future-focused, and change-oriented. If you have heard of the term job crafting, it is a kind of proactive behavior. Employee voice also counts as a proactive behavior. And as I was reflecting and preparing for this panel, I was also really cognizant of the fact that trust is a necessary element for proactive behaviors. And give you two examples through my own research, two real-life examples of proactive behaviors. So for one, the first one involves a physician submitting and receiving a competitive national research grant on their own to promote outcomes among patients with chronic disease. And this particular physician was engaging in this proactive behavior in the name of advancing science. To advance science, I'm going to go out and get this grant. To receive the grant is prestigious, it's national. And the second real-life example from my research is when an attending, in the hope of exposing the resident to more kind of like different training environment, etc., sought to bring a resident to perform clinical rotation at another healthcare kind of like institution. So for the attending, this is great. We can have you, in addition to working at one healthcare system, the attending was really hoping to bring the resident to the other system. So if you were to look at just these two very specific proactive behaviors, you would think that, oh, this is actually really great. People are trying to advance science, people are trying to do training. But what happened in reality was that these two proactive behaviors actually backfired for both the employee and also the organization. So in the case of the physician who went to submit this grant and was very happy and announcing that I got this nationally competitive grant, the chief medical officer was like, well, you have gotten this grant, but we have no means of implementing this project because for everything that you promised in your grant, we cannot do it. So the CMO forced the physician to withdraw from, to return the grant altogether. And for the attending who was trying to bring the resident to another system to do clinical rotation, the chief academic officer realized that actually you cannot do that because we have no legal ties with this other institution that the attending was affiliated to, but the resident basically wasn't. And the resident had no means of doing a clinical rotation there. I'm so sorry, I move with my hands a lot. So, so as I was reflecting about these proactive behaviors that backfired, I was just thinking about, oh, what does it do in terms of trust from the managerial perspective, but also from the employee perspective? From the managerial perspective, it's probably harder for the leaders and managers to have the trust again in terms of, oh, this physician went out there, got the grant, but then now had to return. That was reputational damage. That was a lot of spent resources, etc. And also trusting the attending in the future to be doing things that are within the bounds of what's legal, what's possible for the training of their residents. So one of the conclusions I actually made in my research on proactive behaviors is that just like trust, proactive behaviors are precarious to engage in at the workplace, mostly because employees, they have the agency, they have the motivation, they want to do something that would either benefit themselves or the patients or the organizations, but sometimes leaders and managers have their own set of thinking that may not go hand in hand. And while, I'm sure we've all heard of the term that yeah, we love proactive people, we love innovation, kind of like come to us with problems and the solutions. But the reality is you might want to be solving the problems at work, but they may or may not be welcome because there's so many kind of like boundaries that you have to navigate. So just to wrap up a little, I thought of maybe sharing 3 domains of practices that might be helpful as we're thinking about encouraging proactive behaviors, encouraging effective proactive behaviors, and also by way of that trust, is to share, for managers and leaders to share the unspoken rules at work. Sometimes managers have different expectations. Sometimes they want employees to follow the chain of command. Sometimes for them is, oh, you can just do it and notify me later on. So how would employees know when to escalate, when to notify? That's actually quite challenging to navigate. Want to know for sure is that this particular behavior is not benefiting the individual that much. So when you're saying, oh, I want to sign up for a leadership program, are you doing it so that you can get a better job elsewhere, or are you doing the leadership program because you truly want to keep serving in the organization? So the kind of like little, some managerial kind of like thinking on that front. And of course, there are these hidden boundaries, finances, regulations that may or may not be visible for the healthcare worker. The second sphere, I would call it emoting. It's really talking about emotions. There is research showing that when leaders are self-disclosing the critical feedback that they have received, I have received very critical feedback, negative and critical, in the past. Even by sharing that negative feedback as a way of self-disclosure, the leader actually creates a closer bond with the kind of like people they work with as well. So it's really being in a space of vulnerability and also showing empathetic concern. I'm sure that we will have more conversations around that. But last but not least, I think, yes, we can be talking about communicating, we can be talking about emoting, but acting as a platform for trust cannot be, it is really crucial. There is kind of like research out there that basically talks about when leaders are hoping to foster trust, we have to think about scale, scope, speed, and also customization. What are the needs of the healthcare employees? What are their pain points, etc.? And can leaders and managers be allocating additional resources? It might not be financial, because oftentimes leaders and managers say, well, we don't have the extra money for that. But sometimes it can be more intangible resources like social networks, capital, or I could introduce you to this particular person, and as a way to help people better achieve their work as well. So I'll take a pause here and looking forward to learning from the rest of the panelists. Thank you.
Okay, so write down your questions for Alden, and we'll come back to Q&A after all of the presenters have had a chance.
Perfect. I'm going to take a slightly different look. So I'm really thrilled to be here with all of you today and with those online. I'm planning to share 2 projects that I've been working on with a colleague of mine, Kate Hilton, and others, and Kate's here as well today, to talk about building trust in the healthcare system in 2 different settings and with a more specific population. So the first example to share with you is a project that's been working on building trust in long-term care settings. And this is with the American Hospital Healthcare Association, who initially started, as we started our plenaries today, thinking about trust during the pandemic. There was a grant looking at how can we help and encourage healthcare workers in long-term care facilities to be interested and to want to take the COVID vaccine. The work has grown notably since then, and we've learned a fair bit about trust in the process and really amongst colleagues, as opposed to just thinking about the behaviors that lead to interest in doing a particular behavior like taking the vaccine. So we know that staff will trust their leaders when they believe in them, when they believe that they're valued, when they have a role, when they have a voice. In long-term care in particular, the individuals we're talking about, nursing assistants, medical assistants, are the highest numbered in these facilities, right? There are fewer nurses and then even fewer physicians. So we're talking about a workforce that's incredibly needed and yet feels undervalued or that their role isn't understood. And we know that this really impacts the care that's possible to be given in long-term care facilities, and it impacts the residents and how families feel about having their individuals there. So ACA built a trust course. Kate and I were fortunate to participate in the building of this. That was available. It's actually available to anyone online right now for modules, and then led a Leadership Academy series, which they're still doing, which is a series of 16 interactive bi-weekly sessions focusing on building trust in the facilities. And we've learned a lot from these. So what are the things we've learned? Well, you can see by the green bars, there is some trust in the healthcare system. So we know that individuals, again, this is looking at long-term care facilities, the highest levels of trust with their administrator and their director of nursing. Individuals felt more confident in those relationships. The foundation of trust were least present amongst coworkers. So you weren't trusting your peers. And why was that? We had a lot of theories, and when we were looking into this work, we've worked with hundreds upon hundreds of long-term care organizations right now. There's a lot of differences in how individuals come in, when they come in, who's been in the organization for a long time. There's a lot of differences by age. But we found that nurses also have the lowest level of trust, both with each other and with their colleagues. So we were looking to figure out what was driving this in particular. And what we've learned is we can really move the needle. So we've heard it multiple times that it's impossible to move trust in a short period of time. So we're talking about 6 months and just a few individuals who are coming to every other week sessions for an hour, having a conversation with hundreds of their colleagues. And we were able to begin to see changes in 6 months with staff trusting their coworkers. And as a result of that trust increasing, again, in a 6-month time period, residents and families were able to pick up on this, and that increased their degree of belief of trust in the system. So some of the basic changes that individuals were working on were thinking, do I feel valued? Do you understand what matters to me? Do you understand the roadblocks that are in the way for me every single day when I come to work? And can you help remove those for me? And the easiest way to do that is to be able to just ask, right? So we talk about trust. We know that trust is in relationships, and especially in healthcare facilities, that becomes a microsystem pretty quickly. You build trust within your team. Sure, you need to think about trust with your organization, and the place that it starts is with those you're interacting with every single day. If you do not trust your peers, your colleagues to be able to have your back, to be able to help you if you have a complicated patient load, to be able to know that we now have a patient under isolation, which means it's going to take me 3 times the amount of time to go in and out of that room because of all the donning and doffing that I need to do. Are you going to be able to help cover my other shift? Or are you thinking, nope, I have a role to do and I'm doing that job in my role? And so a lot of what we've been looking at is how do we build the notion of team? Because looking at improving the direct care worker, the nursing assistant, the medical assistant at the point of care, if we look solely at that role and trying to build improvement in that role and decrease turnover, we know it doesn't succeed because we're not working in isolation, right? We're working amongst teams. I'm trying to keep track of time too, Carolyn, so give me a nod when I need to. So I'll share one more example of a different care setting, but again, a similar population. So the Ralph C. Wilson Foundation funded 7 healthcare organizations in Western New York and Southeast Michigan to try to improve the retention of the direct care workforce. Now, that's a really incredibly broad term. Mostly what we're thinking about is the entry-level position. Again, inpatient, nursing assistant, medical assistant, patient sitters, patient transport, in some cases, LPNs. And the goal, along with these 7 organizations, which is being supported by the Institute for Healthcare Improvement, is a 10 to 20% increase in the ability to retain these individuals within 22 months. Some of the healthcare systems that we're working with on the pilot units had 100% turnover in a year. So you're like, I'm sorry, your data is not making a lot of sense to me. When we asked for baseline, it looks like you have more than 100%, so I don't understand that. They're like, yes, we turned over everyone who started in the beginning of the year and half the people who came in the middle of the year. You're like, okay, so this is a starting place, right? We have to know what the starting point is to be able to make improvement. And we thought, well, there's 5 major things that we want to work on with these organizations. 1, do we understand the context that you're in? Do you understand the historical context and the socioeconomic setting that you're in and the challenges that may be present for the individuals that you're trying to help? You need to have the big picture. Are you an employer of choice? Do people want to come to you? When you're talking about a very difficult job of being a caregiver in the inpatient setting, and that is at the same salary or hourly wage as working at Target, which we heard in every interview that we did, there's a real difference in the mental load that we heard Gwen speak about for these individuals. So are you an employer of choice? Do I want to come to you because I have a passion for the role and for being able to be a caregiver for individuals? Do you have great recruiting and training? Right? It really matters how people are trained. When you're new and you're put on a floor, and I think this applies in every single moment in healthcare. I remember my brother-in-law calling me as a medical resident and saying, I'm responsible for an ICU tonight. This is bad. Like, I've never done this before. And he's like, what do you think I do? I'm like, I think you better know every nurse name that's in there, buddy, you know? But he was panicked and calling someone who's not a clinician to say, what should I do in this moment? And then importantly, thinking about engaging in the care team. Again, we're not talking about individuals in isolation. So if you are with a care team, you are providing care for patients as a team, not as an individual, and what does that look like? And lastly, is the role really valued? Do I understand the value of a medical assistant, of a patient sitter? I tell you, I cannot imagine, we were speaking last night, sitting overnight, making sure someone is safe, doing nothing but watching them sleep for 12 hours. That's an incredibly, incredibly hard job that I value, and I think during shift changeover, no one asked this individual how the night was for that patient. They have a lot of valuable information to share. So again, we've been working with these individuals, these sites, for a while, and I just want to share the example of one of them. Trinity Oakland is amazing. What you'll hopefully see is the baseline turnover of 35% in their care team unit to now 0 within 18 months. So of their patient care techs, they have lost none. And those who are trained explicitly by another patient care tech have lost none. And so why is that? Well, they started to focus on the team. They focused a lot on, do we trust each other? They started by just saying, do we understand our communication styles? So we all work in a team together, but do you know that how I like to talk to you is totally different than how you like to talk to me? And I thought you were just rude, but no, that's how you receive information. So they really took those 5. They thought, what matters in our site? How does it matter in our site? And what they've seen is they can reduce turnover, but they can also improve satisfaction of the workforce, again, in a short period of time. And they've seen significant improvements for their patient populations, such as their pressure injuries going down. So with that, I will leave it for now.
Excellent, thank you.
I love the mention of Target.
Dr. Fairley?
All right, hello everyone. I'm Hannah Fairley. Like Carolyn said, I am a 4th-year senior resident in the emergency department here at George Washington University. And I am also going to be changing up the conversation a little bit to talk about house staff unionization. I want to talk about this in the context of connecting a couple of different ideas. So looking at the epidemic of burnout or moral injury among house staff and the movement to unionize, and connecting that back to today's topic of organizational trust. So if you're from GW, you may already know this, but over the last couple of years, the house staff, so that's the residents and fellows combined at GW, organized and voted in our union. and then bargained for, and just this last December, ratified our first contract. Thank you. Very exciting. But GW is not unique in this movement. Resident unions have been forming across the country at historic rates. Since the start of the pandemic especially, we have seen the largest wave of house staff unionization since the mid-1970s. And while I will not go into a full history of house staff unions, I did want to highlight a couple of steps that we have made in the past that are affecting where we are today. This does date back to 1934. We're at the height of the Great Depression. House staff in New York formed the Intern Council of Greater New York to advocate for their basic needs. So this was things like salary, they weren't paid prior to this, good educational facilities, and improvement in patient care. Over 20 years later, the Committee for Interns and Residents, which is now the largest house staff labor organization in the United States and the organization that GW organized under, was founded. The United States then saw a steep rise in the number of house staff unions throughout the 1970s, followed by years of debate back and forth on whether residents were employees or students, and therefore, are they actually protected under federal labor law? This continued until 1999, when the NLRB, or the National Labor Relations Board, declared that house staff are in fact employees, and that solidified the house staff workers' rights to organize and collectively bargain. So let's bring it back to today. We've seen how COVID-19 has illuminated cracks in our flawed healthcare system, and it seems to have done the same within the structure of graduate medical education. Many house staff felt undervalued and unsupported during the pandemic due to things like limited access to PPE, extended work hours, and staffing shortages. When Stanford house staff were not included in their institution's initial vaccine rollout, they moved to organize, which has fueled momentum for other programs to do the same over the last 4 to 5 years. Since just 2021, we've seen an increase in the number of unionized house staff from 17,000 to 37,000. So let's look at why house staff continue to unionize. The very structure of graduate medical education sets us up for the development of burnout and moral injury. The match system, which is the system that takes medical students and matches them with a residency program, locks us into a contract with a program that we may not have necessarily chosen for ourselves. Historically, house staff have not been able to negotiate salary or benefits once there, and often have little voice in the decisions that affect their working conditions. Cultures obviously range across hospitals and across specialties, but medicine in general can have a pretty rigid hierarchical structure, leading to a significant power differential between residents and fellows and those that are above them. House staff also work long hours, also usually with inadequate compensation for the rising cost of living, and sometimes without sufficient medical coverage or mental health care. While attempting to practice the medicine that they spent all of this time and energy learning throughout the years, they are regularly met with hours of administrative tasks and out of scope duties that actually take them away from the bedside and take them away from their patients. So the literature supports that there is a strong association between poor working environments and mental health. We've already discussed that house staff have a very limited ability to influence change in their work environment, and when concerns about these issues seemingly fall on deaf ears up that hierarchical structure, it breeds distrust in the system. And where trust is lacking, disengagement and disillusionment follow. We see house staff burnout and moral injury occur in part as a symptom of this structural disempowerment. House staff burnout is an epidemic. As high as 75% of residents have reported burnout, and residents with the highest rates of burnout are more likely to experience depression and anxiety. Burnout and moral injury are not equal across trainees either. Depending on the source, emergency medicine, so my own specialty, general surgery, family medicine, anesthesia, are all cited as some of the highest rates of burnout. Underrepresented in medicine trainees are more likely to experience burnout, with microaggressions being a significant contributing factor. Those with multiple marginalized identities, such as being non-white and LGBT, reported higher levels of mistreatment and discrimination, which were associated with increased burnout. Female trainees have reported higher levels of burnout due to factors such as lack of female mentorship, dual role responsibilities, and gender blindness. Burnout ultimately affects our patient care. Physicians, including really clinicians, but including residents and fellows, with burnout are more likely to have implicit and explicit bias towards patients and lower levels of professionalism. And we know that burnout is associated with greater incidence of medical errors. So that begs the question, does unionization improve trust? And can it improve burnout and moral injury? And to be completely honest, research is very limited in this area. We do know that unionization provides house staff with a formal mechanism to address their concerns and to advocate for better working conditions. In my experience, this can lead to an enhanced sense of agency among house staff. And if we can use this agency to rebuild the trust in our organizations from the ground up, can this lead to a better sense of well-being? So there's much more that we need to do to really assess the effect of unionization on this idea of burnout and moral injury and rebuilding trust in the broader organization. Especially with the significant growth that we've seen over the last several years, it'll be interesting to see what further research in this area concludes. Thank you so much.
Thank you. And Jody.
Thank you. I'm excited to be here, and there we go. And I'm going to be brief and just sort of bring us back out to look at the stew, I think you called it, right? And maybe sort of see if we can identify some of the things that are in there. So I'm just going to talk a little bit about sort of what do we talk about when we talk about trust? And we've heard obviously that it's complicated, and we're talking about all kinds of things. I think and I just sort of want to go through sort of a set of bullet points here. One of my definitions of trust that I like to go to a lot is that trust is the willingness to be vulnerable to another for a given set of terms. And I like that definition not for its literal meaning, but because I think it breaks down sort of some of the buckets that we often want to kind of think about when we're thinking about trust. So one is that willingness to be vulnerable. It's this like humanity, it's it's a vulnerability, we all know what that means. And we've felt it, and it's familiar, and we know what vulnerability is. So it's that willingness and that sort of, that ability to do it. There's a willingness, there's an option. You choose it to a certain degree, and that's an important element. If you don't have that option, you might not be talking about trust. You might be talking about something else. So the willingness to be vulnerable is sort of one bucket I like to think about. To another, I think underscores a relationality. So whether that's a doctor and their patient, whether that's a clinician and their institution, whether that's the patient and the institution, those relationships there's many of them. And then the third, and it's important to sort of understand which relationships are at play. And some of those relationships are also sort of connected to time. So what's the relationship right now? But then what are sort of the historical relationships between the two people that are being asked to engage in a trust relationship? And then there's the given set of tasks. And Alden talked about that can be a contractual thing. That can be a very sort of transactional set of tasks. But sometimes it's just more about the context. What is the context? What are the conditions? Why? How long is this relationship expected to last? Is it a short-term thing? Is it a long-term thing? So that's sort of the important context that also helps you understand what is the scope, what are the boundaries of trust. So some of the things we know from the literature about what trust is and why it matters, we know that familiarity fosters trust. So the more familiarity you have with those people that you're engaging with, the more opportunities there are for trust. When I first trust has been a major theme of my work for many, many years. And as much as I care about other things, it keeps coming back. And one of the sort of familiar adages is like, well, it's hard to build trust, but trust can be broken in an instant. And to a certain extent, that's very true. But then there's also, I think we'll hear later about resilience, and it's also an opportunity to make mistakes, right? If you're in a trusting relationships and somebody makes a mistake, it's okay because you trust them and you recognize that over the long term they're trying to do what's in their best interest. So there's quality time, there's quantity of time, and that familiarity sort of helps move things faster, but it also can be a long-term proposition. Meeting or exceeding expectations fosters trust. I think we heard a little bit about that in some of the presentations we just heard. But trying to understand what are those, I'm going to say terms and conditions, but again, not necessarily in the legal sense, but what is it that you're expected to do, and do you meet those expectations, can often be something that will begin to show the evidence essentially on the very personal, but also sometimes a objective level that you are trustworthy. Trust, mistrust, distrust, these are all based on real things. It's not like, they're real. And we know that they're real. They're often, yeah. I think of trust as relational and dynamic. It's not, if I build the most trustworthy organization, it won't be that until I prove it. There's multiple dimensions to trust. Sometimes it matters that you're just able to do your job. Sometimes it matters that you're able to communicate in ways that I understand. It's often related to risk and uncertainty, power, vulnerability, safety, and autonomy. So if there is no risk, if there's zero risk in a proposition, trust doesn't matter anymore. So if you know what's going to happen, it doesn't matter whether trust is a part of the equation or not. And that can work kind of both ways. If you know that the outcome is going to be negative, there's no trust. Like there's no starting point even to think about that. And then often it's, again, the sort of final point here is that trust provides it's a limited license. There's a beginning, there's an end, and it needs to be renewed every once in a while. So we're talking today about trust in the workplace, trust in institutions. I feel like this slide kind of speaks for itself, but I think it also sort of underscores sort of how foundational it is to sort of where we live right now. That a body of men or people holding themselves accountable to nobody ought to be trusted. I can't say it, but you can read it. Yeah. So when we begin to lose trust in our organizations, we really, it's hard to move on. And then finally, to sort of, I think about, if we can think about trust as an ecosystem, it becomes, again, sort of an easier space to begin to operate in. And we've thought a little bit in our group about this notion of too big to care. So we heard this morning about, what do you do when a patient, has needs, but the institution that you represent can't provide those needs. And we're really sort of, in some ways, stuck in that system right now where it's too big to care. We also will hear, patients, individuals that may refuse a vaccine, but it's not out of a lack of love or compassion for their children or for children in general. And yet, it's still, so there's part of a system that isn't taking care of them for them to feel a willingness to accept risk, or as they see it. We also were able to hear a little bit this morning about the impact of current trends on health ecosystems, sort of the commercialization of health systems. We're in an environment of, tremendous funding insecurity that has a huge impact on institutions, that will have impact on workforce, that will have impact on patients. Artificial intelligence, sort of new technologies that, again, may be able to help with some of the questions around burnout or administrative responsibilities, but it's also going to help us, it's also going to move us towards moving much faster. And a lot of what we're talking about is moving a little bit slower. And then finally, sort of looking towards solutions as sort of stewardship. And again, if it's an ecosystem kind of issue, having solutions that are ecosystem oriented. That's it. Thank you.
Thank you. Okay, I just want to let you know we can ignore this time.
Okay.
It's like blinking lights up here, but we have another session technically. So thank you all so much for those remarks. I have lots of questions. I want to give any of you the chance to ask each other questions first among our panelists? Anything that you heard and you were like, I've got to jump on that?
I guess I can go, and this might be a very kind of like, basic question addressed to Hannah, and talking about the unionization, because from my very layperson understanding, I thought that ACGME has got kind of like, guidelines for residents. So I was curious about with the unionization in it, was it, I'm guessing there'll be conversations around salary, but also other stuff. So I was curious about what is ACGME not paying enough attention to that basically how staff across the country have to rally and to really probably ask for something that's potentially quite basic, quite foundational for them to do their work well. So I was just curious about that.
I think, especially for our unionization efforts, I don't know that the main issue really was with ACGME guidelines. They have over the years, tried to kind of rein in. We have our like duty hour limits that you can't work more than 80 hours in a week. You can't do more than 24 hours a shift plus 4 hours of additional work, so kind of 26 hours. So there have been those developments over the years that have helped in the well-being of residents and trainees. And I think variable across the country, across programs, you'll see different implementation of those. I mean, it's an accreditation body, so it's part of what keeps programs afloat to follow those rules. But you'll see the culture sometimes, and none of this is speaking to GW specifically, this is kind of in the broader sense of unionizing. But you'll see it across different program cultures or different specialty cultures where that gets bent a little bit more. And I think the point of residents coming together as one body is to kind of push back across some of those things that might be more institutional variations on that. I know, kind of speaking to our personal, we felt the moral injury, there are things in our day-to-day that are not allowing us to take care of ourselves, which makes it harder to take care of our patients. And so that was really the motivation behind what is it that we can do to elevate our voices so that the broader organization can actually hear our concerns, and maybe we can influence change that affects us but also changes things for our patient care.
Thank you.
I have one. I'm thinking you ended by saying we need to move a little bit slower, and AI is encouraging us to move faster. Healthcare in general, we're always trying to, if I think of myself as, if I follow Gwen's lead and I think of myself as a caregiver, as a mother and a wife, I think the most trusted relationships I have are those that feel slow, those that feel like I have time and space for conversation. And yet, what I see a lot working with organizations is we have to prioritize. And the priority can't necessarily be the direct care workforce, or we have a lot of system challenges, right? So how do you see the selling point of we need to be a bit slower to actually be able to move faster, I think, to be able to be a bit safer, to be able to have the outcomes that we want? We need to move slower doesn't feel like a solid selling point at the CEO level.
It might not, but I would point them to your study, right, where you have, you have very specific outcomes that management really likes, right, like reduced turnover.
They do.
Right, and so if you can, we need that kind of sort of evidence so that that moving slow short term is going to end up sort of moving, because once you have those relationships, so if you have you need to talk with your partner about picking up kids at school, it doesn't have to be a discussion, it just happens, hopefully, and you are confident that it's going to happen, right? And if it doesn't, anyway, there may be asterisks and caveats to that, and maybe it doesn't work 100% of the time, but most of the time that trust eventually helps you move faster. But I think it's that slow, and again, I think your work showing that 6 months is not, forever. It's a fairly short period of time into the, health of the organization. So, I don't know. What would you say?
I think we have almost intentionally not shied away, but we've realized that we didn't need leadership on board other than to agree for the teams to do the work. So we needed leadership engagement at that level. It helped that there was grant funding that went along with it, so leaders are less likely to say no. I think it's okay. I think once we have the results, then it's an easier sell.
Yep.
It's kind of the being able to go to the organization that you're not able to go to grant funding with and say, I think you really need to make this investment. That's the harder pitch, because it's very real that there are competing priorities. I'm not saying that there aren't. There are competing priorities, and when you're talking about managing a very fine line between, a successful year and not, and you have hundreds of thousands of employees you're responsible for, I think that's fair. So I guess data, I would say, is our best way forward. And probably thinking about language, I think, is the other piece. And I think that's what we don't quite have yet, is thinking about the right language for different audiences to draw them in.
Yeah.
And I think getting the language right for those audiences without alienating the others. So you go to the leadership and you sell it solely on the basis of retention and cost savings, because you don't have to do so much hiring and training and turnover. And then you go with the same body of work to the direct care workers and you sell it on slow relationship building and team dynamics. And that is a problem, right?
Yeah,
like you're
feels
using the same
disingenuous.
language, different language to describe sort of the same body of work and the same approach. And that can be confusing for a lot of reasons, and to both audiences about what the goal is here. Like, are you just doing this to save money, or are you doing it because you really care about me as an employee? I think is a reasonable question for someone to ask. I wanted to ask, this is very on point, about, we framed this as trust in organizations. And I'm beginning to think that what we're talking about is trust within organizations much of the time, or at least that the trust within organizations between team members, the kind that facilitates proactive behaviors, is a different kind of trust than the trust that we must have in a CEO or leadership team. And what do you think of that hypothesis? And if you had to sort of bet, like, which is more important? Is it trusting CEO and leadership, or is it trusting team dynamics? Or maybe what are they important for anyone?
Go ahead.
I think a lot of individuals who work in healthcare systems do not necessarily know the CEO and the leadership team. I think that's really important. I think it guides the direction of the organization. And if you are fortunate enough in your life to be able to make a choice of your employment based on values and the direction an organization's going in, I think that's incredibly important. And if you are struggling to make ends meet and you need a job that feels stable, that you can go to, that works with your life, then I think you think less about that more advanced level, and then the very close team dynamics. I think the team dynamics matter for everybody. That inclusion of the senior leadership is a smaller subset of those individuals, I think.
That's really interesting. And I think thinking about the hierarchies within organizations, and we've heard over and over, they're extremely hierarchical organizations. For the direct care workforce, they don't know the CEO, but maybe clinicians do,
Yes.
right? In a way that feels more significant. And so there you're talking about more complicated
Right.
trust dynamics.
Well, and that leads to your matching discussion as well.
Yeah, I think the goal of unionization most of the time is to affect change that's going to be on a more systemic level, that's going to rise up kind of through those ranks of the hierarchy. From the experience of having just unionized and having a brand new contract that's still trying to be implemented, have we seen that change on a structural level? No. But the process of organizing and coming together to bargain, the kind of trust between all of our different specialties, because we have our little microcosms of all of our different specialties. There's the EM residents and the IM residents, and we've seen the trust build across the house staff as a group, and I'm hoping that that continues to grow, that then we're able to build trust outside of just the house staff, and we have more trust in our faculty, and then we have more trust in our institution, and that helps build that change that we're really wanting to see.
I'll just take a quick stab. I really think that trust within organizations and trust in organizations, I think it really depends on the context and the situation. So from day to day, I mean, you were talking about how at the beginning of your project, you were letting team members figure out each other's communication style. So I think that with the fostering of trust among team members, it also creates social connections and social belonging. And we know based on research that social belonging is a huge predictor of well-being. So with that, but I think trust in organizations, I think the situations that call for that would be, for example, shock events, like COVID-19, for example, and when suddenly funding is gone, when suddenly regulations are changing, that's when people's sense of what should be normal is totally collapsing or being disrupted, and that's when they have to feel that they could trust the leadership and management to be continuing that sense of like, this is what we're here for, this is what we stand for. So in the management literature, there's a whole term called sense giving and also sense making. So we do sense making day to day about what our work lives involve. But leaders and managers, they also have the responsibility to be doing sense giving to, especially when people's kind of like frontline workers, when they just need to know what's going on with external shock events, that's when it's so crucial. So I think it really just depends on the day-to-day. If the day-to-day is really, things are normal, you're working with your coworkers, then trust within teams, managers, divisions, units would be more crucial. But I think there's some circumstances when trust in organizations really would be extraordinarily important. So that would be my take.
Yeah, that's really, really important and speaks to the importance of constantly building trust in organizations while you're doing the team dynamic within organization type of work.
Right, yeah. Jody was talking about it has to be renewed. So I think I took a note on that. It's not a one-time thing. It has to be renewed. So maybe we can talk about this later, but I was curious about how do we renew that? Can we be intentional about that, or do we have to wait for some event and then we can try to renew trust? So for me, I think that's a really interesting kind of like thing to think about. Yeah.
Yeah, I mean, I think when we think about, we have renewals of renewals of contracts, right? There's renewals of, systems. Like there's an updated process. I feel like at the moment, systems are getting worse at it than they used to be because nothing's ever done, right? It's when you're done that you sort of face a renewal time, but we don't have that as much as maybe we historically have in some contexts. I don't know. It's observation.
Can you give an example of a done thing?
Of a done thing? Well, that's the thing. It's hard, right? At the moment, it's really hard to think about a done thing. But when you leave a job, that's one way of somebody saying, I'm ending this, and I'm going to start something else, and I'm going to find a new place. Or if you're looking, you're on the job market, you still have your job, but hopefully that sort of opens a window potentially for a renegotiation where you are. But yeah, we don't. There may be, in the technology space, you have licenses that need to be renewed, issues of, annual issues. Like there's sort of these sentinel moments where they may be, but you usually don't think about building in sort of an active trust building exercise. I can't give an example of that.
Yeah. I want to invite audience members to come to the microphone as we continue talking. So please, hope you wrote down questions for our panelists. I was struck for a couple of the presentations about what seemed to be the importance of organizations trusting their employees And we've trust in organizations, sort of we're imagining trust going one way. We know trust is relational, it's dynamic. And I wonder if any of you know of research the other way. Organizations trusting their employees, and maybe Lindsay, your cases kind of speak to that sort of, and the notion of self-directed proactive behaviors is sort of like you feel like you can do your work and you can lead in some way. Is that a form of trust?
I think it is a form of trust for you to be able to say, for me to have the confidence, in whatever system I am, to be able to say, I see a problem, I see a challenge, and you trust me to be able to fix it and to be able to act in this moment, and then I think have a learning system within the organization that says, I fixed it here, and we could fix it in every other med-surg unit or in every other ED. Like, I think that's where leadership has to trust the staff to say, you've solved my problem? Like, I can do some investment in the front line to be able to get major gains. It's different though. Kate and I have been talking a lot about this. So, trust at different levels, thinking about do leaders trust their staff and do staff trust their leaders at the next level feels, trust is the same idea, but it's a different set of dynamics than thinking about I'm building trust within my team and I have the ability to then do my job. The moral injury, we were sharing some stories last night, and there are examples of nursing assistants that have 27 patients in one shift. Like, that's not, you don't have trust in your organization because you know it is not possible to do your job at that point. And yet you really want to, right? And you really care about the role. So I think that there's also a gap of, do leaders even know that that's happening at that level?
It kind of reminds me of like set of tasks that you have to be trusted within a limited sense, but the tasks are too great.
The tasks are too great.
For a lot of healthcare workers.
Yeah.
And you've been trusted with too much.
Too much.
I mean, you've been expected to do too much, and trusted is probably not the right word there. And so it just breaks down. I mean, there can't be trust where the task is inappropriately sized.
You can't meet the expectation. If you can't meet the expectation, you're no longer trustworthy. And that's that sort of vicious cycle that I think you sort of alluded to.
Or you might think, I'd be great at this with 6 people. I'm amazing at my job when I'm staffed correctly, and I'm definitely going to fail with 27. Right? Because there's no way not to.
Yeah. Yay, an audience member. Yes. Tell us your name, please.
My name is Victoria. Nice to meet you guys. Great presentations all across the board. I just was hoping that we could go into a little bit how to approach the trust rebuilding process, especially if you're in an organization that has that 100% turnover rate. How do you, because I'm sure there's rumors in the community about, well, this place is kind of not the best to work. Maybe people that are currently there aren't super open to engaging in that kind of thing with the organization just due to past bad experiences. So how does that start?
It's a great question, and when you do have 100% turnover, you're right. Like, you're not known to be an employer of choice in that moment, right? I think we can all agree to that. One of the most important things that we saw is as we were setting up who was going to be on these pilot units and who was going to start, the direct care workers had to be a significant and equal part of the team. So as they came to learn, they needed to be freed up, their time needed to be covered, they needed to be a part. But I think to start, one of the single most important things we did was say, what are the pebbles in your shoes? What makes this a terrible day for you? And there was real hesitation, like, nope, no one asked. So I said, okay, well, what would make a great day, right? And then the floodgates just opened. So the things that are driving me absolutely crazy in my day are, I don't have enough linens to be able to do my job. And it's like, but we do have enough linens in the organization. Well, they're not here every day when I need them. And the manager might say, but I put the request in for this number, right? And incredibly simple solution was get a yardstick, make the note, give the yardstick to the linens department, who does not have time to count 150 towels for you, but they can say, okay, I need this much to that floor every day. Problem solved. Well, if Jody just solved my problem that way, I've now started to think like, wow, things can change. I do have a voice. What I'm saying does matter. And so we started very, very, very small at the level of what matters to you and what is stopping you from doing your job today. And we made it very public. So they wrote it down, they put it on boards, they asked the whole staff. They started by saying, how many people feel like we actually have like a good team here? And we let them drop ping pong balls to be able to see. It's so gratifying to drop the wrong color ball if you've had a bad day. But that someone was then doing something about it, right? And so if you dropped the blue ball and said it was a bad day because, you know, I was overstaffed and I couldn't get to this, this, and this, and then the nursing staff got mad at me, like, okay, well, we need to address that. And then we very consciously the next day start to work on that problem. I think it takes time, and it does take working together. So often, we really are in bad systems that have created these problems. We're not dealing with bad people. Periodically, we have some individuals that it's time for them to move on, and we can all understand and accept that. And if we're, 90% of us have moved and 10% haven't, then perhaps this is no longer a great fit for that individual. But we started, the amount of effort that some of the core team members started with, things that you might not think matter at all, but, bring your picture of your pet in. And now we're having a conversation about something other than work. Do you know the children's book, Have You Filled Your Bucket Today, by doing good for others? Okay, so we've seen organizations that now have little tiny buckets on the wall and then started leaving notes for each other. This is what you did for me today, right? And you don't have to sign it, you don't have to say what it is, but it started we thought it would be just between the direct care workers who decided this would be a really fun, cool thing to do and created it. And what we started seeing was the direct care worker to the physician, to the nurse. We started seeing very bi-directional interactions, and it takes time, but as you're working on projects together centered around patient care, and if you've then been put in a position to be able to do your job, if you now have 8 patients instead of 27, your whole attitude might change, right? And the things that you're coming to work, your frustration with me might be because you can't do your job. It might have nothing to do with me. So we do encourage and focus a lot on food too. People love to get together around food. They do, right? And so we do that, and we talk about things that are not work-related, because as I understand more about you, you understand more about me, it may help me understand why you're so frustrated.
Hi, I'm Rick Burzon. I'm in faculty in global health in the School of Public Health. My question actually, which I've been pondering a little bit since Guinevere, you gave your remarks, and this issue of the availability of healthcare providers to really spend time with their patients, which has been an increasingly obvious problem in this country for many years now. And it really stems from the fact that, as you mentioned, we live in a capitalist society, and there are very few firms that actually care about the issues that you put on the table to consider, because they're mostly interested in making money. And that has, of course, that affects the healthcare system. And so what I'm wondering is the extent to which maybe to change public policy and affect change, we need legislation through the federal process. Maybe not in this administration, but maybe in the next one, to address some of these issues, because as long as healthcare providers work for companies that really don't care about patients, they care about making money, things are not going to change, period. It's just not going to happen. And I've just seen this in practice myself over the years. So is it possible to introduce and pass legislation to address these issues? And if not, how do any of you think that we can move forward with this issue about patient care? Thank you.
Thank you. That was going to be, I had a related question follow up to this, is sort of what if when the problems are policy and systemic, society-wide problems, right? It's just the leaders of the small rural community hospital cannot get any more money out of the system to pay more direct care workers, to have the ratios that provide them any semblance of a quality work experience. And I don't know. I mean, it's just sort of like, how can you? Is it possible logically to build trust when the policy and economic context is such as it is? Maybe you have the answer, sir.
I was going to say Kaiser. The first people talked about private equity being a problem, and Kaiser seems to have a better model. They spend more time with patients, and I was lucky. I got a new doctor. My former doctor went to work for Merck, and he has a specialty they needed. And my new doctor's a former administrator from Planned Parenthood, and she spent a bunch of time, and she ended up recommending vitamin D, and it worked. So it's pretty simple, but she put some time in, and Kaiser puts time in, and there were also union, OPEIU. I was wondering what your international was, and about the politicalization. It seems like there are personality cults. So there's like a Trump personality cult, and there's a Fauci personality cult, and the Princeton University Press published a book called In the Wake of COVID about how to regain trust, because we were gaslit about the origin of COVID. And I recommend the article about In the Wake of COVID in The Guardian, and there was a New York Times podcast, The Daily, interviewed the authors of the In the Wake of COVID, that there's this mass gaslighting, so people are trusting the wrong people. Thanks.
Jody, I know you have experience with that trust ecosystem, and maybe you can just sort of connect dots between trust in science and trust in this context, or do you see any dots?
Politicalization, like, one is what the guy before me said about money, like squeezing poor people to give billionaires more money, and the other was covering up, because if you're in the business of gain of function research, you're going to say that COVID wasn't caused by gain of function research. So it's conflicts of interest.
Yeah, I mean, I think you both sort of, really sort of, I don't know, articulated very well sort of the conundrum. Doesn't even sound like it's too small a word to describe what you just did, but that, and it also, I think, it often feels quite intractable because it is so large and everything is connected to everything else. there's a large body of literature around sort of the difference between like trust in senators and trust in government. And people are much, you can shake a person's hand. There's no hand to shake when you walk in the front door of an organization. And I think it also sort of underscores what makes it so hard for frontline workers, because they're that face of the organization, whether they believe in what the organization is doing or not. And so it becomes, it's a big problem. And I think the solutions in terms of, working from the bottom up and working with the people that are that front are going to sort of help us hopefully do some rebuilding. There are also obviously many policy interventions that hopefully can help chip away at that. What are the incentives and realigning incentives? I grew up in public health, and like that's one of the common themes of things. It's like, how do we realign the incentives? In many cases, that's a policy question. Say one last thing, and that's a mentor of mine, again, many years ago, used to talk about health policy as the sort of coming together of community values to decide on a course of action. And so I think if we can, whether we have a federal process or not, to the extent we have state processes, et cetera, if we think of policymaking as that coming together of organizations, identifying values and setting out a course of action, then that is sort of, I think, aligns with a lot of the trust building kinds of thoughts that we've had so far this afternoon.
I think too, as you come up with, I'm thinking of the conversation we were having last night where hospitals are playing roles they weren't necessarily intended to play. So if we think about the overworked nature of staff, and we think about sort of definitely the impact of mental health on acute facilities they're not equipped to be able to handle it, and yet they are sort of the only resort right now. There is room sort of at a local or a system level to say we don't have the right people in the right places. And so if we, even recognizing that there is one pie and that their financing is limited, are we able to care for people in the right settings, and what does that actually look like versus me being focused on my hospital setting and you being focused on your long-term care setting and you being focused now. All easier said than done, I recognize, and I also recognize we're not sharing funding across these systems. But I do think that is where there's opportunity for policy intervention at a local level, which feels easier than even at a state or federal level.
You've got to do this stuff at a federal level. You just have, I was a friend of Fitzhugh Mullan's, and I worked for his wife, Irene Mullan, at NIMHD for many years, and they were very much aware of these issues. And in fact, I'm very pleased that GW has this institute named after Fitz, because and he would be very pleased about the whole thing. But he was aware of these issues, and I'm sure he spoke about them on a regular basis. But this is the kind of thing, it's not going to happen on a local level. It's got to happen on a federal level.
One thing that does seem true is that political action at the local level can create the political will to take action at higher levels. And so maybe that's one little bright spot. We've got a head shaker, totally fair, but that you can catalyze things when they feel impossible. I'm sorry, go ahead. We have 5 minutes left now, folks. So
That's okay, I
please
jumped
come
the
forward.
gun. There were lots of great answers to that question. I'm Gabriella Cipolla. I'm a health equity researcher at the American Federation of Teachers, which is actually one of the largest growing healthcare unions in the US. We represent over 250,000 healthcare workers, so not just teachers. And Dr. Pippin has done a lot of great work with us. So my question is for everyone, but probably specifically targeted at Lindsay and Alden. I'm a unionist, so the answer might be skewed here, but I actually was wondering how you can start to even build trust to have these conversations between labor and management, to give labor a safe space to share their experience as they're coming together in these committees or in these research projects. So if we're thinking about a rural community where the hospital is maybe underfunded, but also has an employment monopoly in the community. And as we are looking at this this profits over patients health equity, private equity crisis in our country, what is even the motivation? How can we get the motivation for management to even come to the table and begin these research projects to have labor share their experience in a safe way without retaliation? Because as Hannah well knows, unionization is a long and very enduring process, a very necessary one, but not one that can be done in 6 months. And congratulations on your contract.
Okay, I'll start and then I'll pass over. I think, honestly, data is incredibly important and helpful. I think the ability to be in a place where you can tell stories. So a lot of us have referenced back to our opening story today. Stories make a big difference. They give us a way to anchor what we're seeing and what we're learning. And a lot of times, the individuals who are responsible for, at the CEO or CMO or any C-suite level, they've come up through the system, right? Like they went into healthcare for the right reasons and because they cared about people, and now they're in a different role where they're feeling a lot of pressure. I think the ability to share stories along with data of this is what my day looks like, and here are where things went wrong, and I think they could have gone differently. I think the other piece I would say is that I find I love doing collaborative learning, having a set of organizations that are learning together, because when I walk into an organization for a site visit and they say, that's all good and fine, you might be able to do that in Boston, but we can't do that in Michigan, and I'm able to say, I hear you, and I was 30 minutes down the road this morning where they are doing it, and maybe like a little site visit would be helpful. But I think the ability to learn across and with others and have those examples, right? So you telling me your job is hard is very different than saying, this is how many patients I was tasked with. Here's the things that didn't happen today. So I'm a patient sitter. I had a 12-hour shift, and I was never given time to go to the bathroom. That's something that a leader wouldn't know, right? We assume they know the difficulties, but I think that assumption is a problem.
Thank you for the question, and I totally agree with Lindsay as well. I was just going to say, in response to Carolyn's question early on in terms of how do organizations trust employees and workers, I think one way is through competency, which is what Jodine was talking about. But I think the other part that we have kind of missed talking about is organizations' trust in people's lived experiences. It's really the workers' lived experience on the front lines that they know their patients, they are able to foster local practices that are innovative, especially maybe in under constraint, in settings that are more resource constrained, maybe rural settings, for example, and they try to make the best of what they can. But in the process of making the best with what they have, they come up with something innovative that I think then requires, or basically it's going to be beneficial when organizations pay attention, when the leaders could pay attention to those innovative practices as well. I'll just do one thing quick, is that we often talk about employee voice, that we want people to share, like, what are the pebbles in your shoes, etc. In my own research, I find that employee voice is a double-edged sword. If people are really risking a lot when they are voicing certain things, right? They're risking retaliation, maybe their job is on the line, but they feel this responsibility to share something. So when they share and when managers respond, that is a positive outcome. But when they share and nothing gets done in return, and if you keep doing that, that is actually a negative outcome. It's even worse than not having, kind of like employee voice at all. So it is a double-edged sword. So we just have to be careful about sharing the processes and what are people doing in response. So to people sharing. So I think just crucial practices.
Thanks. And just before I make my comment, I think, Aldo, that's a really interesting idea in regard to the promise and pitfalls of unionization, in that it does raise expectations of change, and it can, in turn, even if objectively the conditions don't change much, your satisfaction with those conditions can fall because your expectations are higher. And I think that's the challenge of unionization, is that the expectations are so high. And I think a lot of the work that I know AFT has done and SCIU, and we'll hear some from UMass Memorial around trying to basically address some of the non-economic sides of the contract. I think there's been less attention paid to that than there needs to be, and I think that a lot of union leaders are beginning to catch on, particularly for professional unions, the issue of bargaining around who controls the system of delivering care and in order to improve access and quality. However, I wanted to respond to my colleague, who's a friend of Fitz's, like, good to meet you. And so, I mean, I also believe that many, I mean, I think on our panel today we had sort of some voluntary approaches, we could say, where you have to get the buy-in from management and then you can do small things. And we have, let's call it a more mandatory approach, which would be, you know, even if you don't like it, you're going to have to change. And I think it's interesting to think about those two approaches as probably both necessary and not an either or. But for the issues that Gwen raised, which are about essentially the forces that are external to healthcare organization that are making management act the way that they act, and in so doing, preventing clinicians from providing care to patients that they need and deserve, which is the crux of the problem. I do think that we have to think, in addition to the sort of voluntary and mandatory within organizations, external forces. And there's a lot going on that is tangential to building trust externally that we don't usually think about in terms of trust. So, for example, actually, Gwen, you mentioned the FTC stuff and about having situations where nobody can change jobs. There's no competition for the employer of choice, which obviously is something at a federal level that can be addressed. A lot of the labor regulations are at the state level, however. So the right to work, which makes it very hard to unionize, or mandatory overtime, all of those regulations are state level and they really matter. Ratios for nurses, that's at the state level for now. It could be at the federal level. But those changes often happen in states that are at the forefront of being more worker-centric, and I think that they should be looked at in the context of building trust as well. And then lastly, there's an idea, and I won't claim credit for this myself, but Wendy Dean, who is a leader in the area of moral injury, particularly for physicians, has an idea around creating a registry of CEO accountability, because clinicians are liable for their work. CEOs get away with murder, literally. And unfortunately, they don't always come up through the ranks, Lindsay. Often, in Wendy's book, she talks about people who come from shoe factories, and their whole frame is how to cut costs and increase profits, and they know nothing about healthcare. And we see that more and more. And we see the larger and larger organizations where the accountability of the C-suite is less and less, because they're no longer walking the halls of the hospital. They're actually probably don't even live in the same state. And so that accountability is getting less and less. So this issue of how do we build accountability for these issues at the federal level, I think, is an interesting one. And part of that could also be data, although we've seen with pay for performance that data is often tied to such a minuscule amount of money that it doesn't end up moving the needle. But if there were public databases around even things like turnover at the organizational level, or in addition to the more distal outcomes of patient outcomes, it could help create a climate in which you could do more voluntary, there would be more leaders interested in the voluntary approach, and maybe more leaders also interested in making unionization less of an antagonistic kind of a thing. So I guess where I come out at the end of the panel is we need it all, and that it's not either or, but it really has to be thought about at least at those three levels and probably other levels as well.
Thanks, Polly. I think we should let that be the last word, unless our panelists have anything else in response. All right, great. Well, thank you all for participating, and thank you to our panelists. I think we earned our break.
So we're going to transition to the next panel directly.
We are? Oh, we are? I think there's a break on the agenda.
Okay.
There's a 15-minute break on the agenda.
Over-enthusiastic.
self-score.
Oh, that's amazing. Okay.
Third chair.
Well, you need to.
Amy, you'll be in the fourth chair.
Okay, you got it.
Yeah.
Over there, next to Amy.
Sit where I'm supposed to be.
Now is when my teenagers call me.
What's that?
As soon as we get on stage.
Yeah, exactly.
The right order.
All right, can you hear me okay? Great, we're gonna go ahead and get started. My name is Randall Dent and I'm so excited to be here moderating the second panel of the day. In our first panel, we heard from a fantastic group of speakers about why trust matters and what happens when it's missing, for both health workers and the patients that they serve. As we heard in those earlier conversations, trust in healthcare has been tested and in many cases, deeply fractured between leadership and frontline teams, across departments, and throughout entire systems. In this session, we're fortunate to be joined by 5 leaders who have moved from intention to action, implementing concrete strategies aimed at rebuilding trust within their health organizations. Together, we'll examine what's worked, what obstacles they've encountered, and where they see this work going next. So I'm briefly going to introduce all of our panelists, and then we'll get started. So first will be Cinda Hilton-Rushton, an international leader in bioethics and nursing, who is the Anne and George L. Bunting Professor of Clinical Ethics and Nursing at the Johns Hopkins Berman Institute of Bioethics in the School of Nursing. She is the editor and author of Moral Resilience, Transforming Moral Suffering in Healthcare, and co-creator of the Rushton Moral Resilience Scale. Dr. Rushton is the Chief Synergy Strategist for Maryland's R3 Resilient Nurses Initiative, which she will talk more about in her presentation. Will Erickson works for SHARE UMMH Labor Management Partnership Office as a continuous improvement coach. His primary responsibility is supporting the partnership's unit-based teams program, an initiative designed to improve the way frontline staff feel about coming to work each day. They do this by engaging them and improving their most challenging processes. Amélie Roux will speak next. She is a French hospital administrator. She's worked with the French Hospital Federation and as the head of the Department of Human Resources, and in her most recent position was the Director of General Affairs and Communications at the University Hospitals of Lyon. She's currently spending 1 year at the Mullan Institute as a Commonwealth Fund Harkness Fellow in Healthcare Policy and Practices. Next, we'll hear from Amy Locke, who is the Chief Wellness Officer, Director of the Osher Center for Integrative Health, Professor of Family and Preventive Medicine, the Co-Director of the Driving Out Diabetes Initiative, and Adjunct Professor of Nutrition and Integrative Physiology at the University of Utah. Dr. Locke has internationally recognized expertise in professional well-being, innovative curriculum design, and transformative clinical programs to address lifestyle and prevent disease. Lastly, we'll hear from Corey Feiss, who is a healthcare executive with over 20 years of experience. He is the CEO and co-founder of the Dr. Lorna Breen Heroes Foundation, and Corey recently served as the CEO of the University of Virginia Physicians Group. Corey has authored numerous publications on the need to support the well-being of the healthcare workforce, and his advocacy efforts resulted in the first federal law focused on improving health worker well-being, the Dr. Lorna Breen Healthcare Provider Protection Act. So thank you to each of our panelists, and we'll start with Dr. Rushton.
Bless you. Bless you.
Thank you for inviting me to be a part of this august panel and to be in this conversation. What I'm going to share with you today is an innovative platform that we have been partnering with to address some of these issues that you've heard so much about already today, which has to do with the slides not moving for some reason. There we go. So this idea of trust actually is an area that I've spent quite a bit of time working with and thinking about. And during the pandemic, we did research looking at the intersection of moral injury, moral resilience, and organizational effectiveness. And as part of our sample, we had a subsample of people who responded to qualitative findings, qualitative questions on our survey. And of the people who responded to that invitation, the majority of them had clinically significant moral injury scores. They needed to tell us something else. When we did the analysis of their responses, we found that the core issue was broken trust. And we've heard that again and again. It has been replicated in other studies that we've done and others. As a part of our analysis, and this is not working, so could you, next slide, please. So in our analysis, we used a model of trust that's been developed by Dennis and Michelle Reyna. They have been using this model in many, many settings, organizations, different types of sectors for more than 3 decades. And we use their model as a way to try to characterize the kinds of behaviors that were breaking trust. In their model, trust begins with our own capacity for trust, and how our own capacity for trust can be expanded or contracted depending on the context that we're in and our own life experience. Their model is very much focused on behaviors, and they describe them in 3 buckets. Trust of character, which is about how we manage expectations and have clear boundaries, how we are able to keep our agreements and be consistent. It also focuses on trust of capability, and you've heard this theme this morning about the trust of capability is recognizing that people do have skills and capacities that they can be relied upon to bring forward and to involve them in co-creation and making decisions. The other area was communication, and in our research and in the Reyna's research over many years, trust of communication is one of the most vulnerable areas of trust. And we heard that theme again and again and again. So when you think about that, next slide, please. You can easily go back very quickly to Daniel Kahneman's work, and we've heard about the idea of thinking fast and slow. I'm going to need a little help here with this. No, it's not working.
Just 1 sec, sorry.
Technology. So just to reorient, thinking, we heard about fast and slow thinking actually earlier today. And if you recall, fast thinking is that more quick, impulsive, kind of reactive way that we communicate, which is largely how we communicate in most settings these days. And slow thinking, which is more deliberate and reflective and nuanced. And when you think about the combination of thinking fast and slow, when we're in this more transactional fast thinking, it's more likely that we're going to end up with communication mismatch, and we might feel disengaged and agitated, and we're certainly more likely to make mistakes. So if you think about that model and you think about how we might be able to slow down communication and to think about what technology might be able to do to help us do that, we were very fortunate in our Resilient Nurses Initiative in Maryland to become acquainted with an innovative platform called Slow Talk. And we used it in our statewide initiative to engage nurses to talk about the narrative about our work in nursing and to engage them in helping to identify what was missing. One of the key themes in the responses was lack of relationships with their leaders, with their peers, with their patients and their families, and with themselves. So I'm going to share with you one of the audio clips from their responses.
I feel like there's this chasm between administrations and nursing that is huge. And there's a bit of a lack of leadership in nursing that speaks to the spirit of what we bring to the table. And all of the old methods don't seem to be working.
So from this report, we partnered with one of our health systems at the University of Maryland and one of the nurse leaders there to see if we might be able to use this platform to bridge that gap between senior nursing leadership, the nurse manager, which is the middle manager, and the point of care nurses. And so as we began to explore this, obviously, we wanted to create a psychologically safe forum. We wanted to really understand the frontline and nurse manager experiences, and importantly, to take action. So they partnered with Slow Talk to create a conversation using this conversation platform to discuss some of those issues. And in doing so, they were able to create what they call a relational leadership cycle that begins with using this platform to create a conversation around key topics that are important for some time of feedback from either nurse managers or frontline clinicians. And so creating that conversation and then engaging, in this case, nurse managers to sign in on an app at a time that was convenient to them in a small group facilitated conversation with their peers. And so in doing that, they were able to engage people. And one of the big challenges for most of us is we can't get people's feedback in settings like this or town halls or whatever forum that we're creating. And this creates a place where everybody's voice can be heard. So the first question that they took on was the question of relational integrity.
So, when and how is your relational integrity most challenged at work?
So everybody in the small group, like if we were doing a focus group, would have a chance to respond.
Naomi, let's start with you.
Each person is given a period of time to respond to the prompt. All of the information that is collected is then analyzed using AI technology for sentiment and content analysis. And from that then, a report can be generated that summarizes the themes that came out of all those slow talks where everyone responded to the same questions. And by doing that then, it gives the leader direct feedback that they can then begin to act upon. And so by doing that, they were able then to go back to the same group of people. These are the things that I heard. And now let's have a second level of conversation about a particular topic like relational integrity. Then from there, they're able to distill those responses, again, using AI technology for analysis to come up with the next sort of layer of conversation that needs to be discussed. It also provides the leader with what the low-hanging fruit might be. So what can we do right now? What requires further discussion? What are some of the things that aren't possible now? So in this context, we're able to have realistic expectations about what is possible. And engaging the people who are most concerned about whatever the topic is in designing the solutions. And so by doing that, it really addresses a very important leadership challenge where we're kind of, pray and spray, we're hoping that the right people will respond, that we're able to really engage in a safe way where people can tell us what the problems are. And it gets over that meeting mania that we all experience and have the opportunity to really focus in on the things that really do matter. What we found in this was that the nurse managers who participated in this conversation with their executive leadership felt like it was an important tool that they could use with their frontline staff. And so what the next step is they are actually using this slow talk technology to engage frontline nurses in discussing the things that really do matter to them. They've also created a sense of community and belonging. They realized they weren't struggling on their own. They also realized that they were able to be authentic in conversations with their peers. So what you can see here is dismantling some of the barriers to actual trusting relationships by creating an enabling platform that allows people to be honest, to be able to see that their feedback is actually heard, because everyone receives the report just like the leader does. And then the leader can respond. So that's all.
Okay. Okay. Hi, everybody. Hey, Will. Did I do it? Okay, great. I'm Will. I am an organizer by background. I worked in the labor movement for a couple of decades, and now work for our labor management partnership at UMass Memorial. So I'm going to tell you the story of what we're doing through our labor management partnership there. So first, a little bit about our system. UMass Memorial is a mid-sized hospital based in Worcester, Massachusetts. It's the largest employer in the region, largest healthcare provider. Many of you probably get care at places like this, or have worked in a place like this. It is also the largest safety net hospital in the region. My story is about our hospital system's partnership with our largest union at UMass Memorial. The reason it's the largest union is that it represents the most job titles. So most of the people who get paid by the hour, nursing assistants, medical assistants, billers, rad techs, respiratory therapists, pretty much everyone who's not an RN or a physician is in this union. And this is the union I came out of. It's affiliated with the Harvard Union of Clerical and Technical Workers, which is where I interned like as a 19-year-old. So I've been hanging around this group for a long time. So in 2016, close to our 20-year mark, we were reflecting back on what we had accomplished through our union and felt good about a couple of relatively traditional issues that we had made progress on, but we were dissatisfied with how much we had actually changed how our members felt about coming to work every day. If anything, it felt like our members were working harder, they were more discouraged, they were more frustrated, they had more difficult relationships in their day-to-day work. So it felt like somehow we were moving in the wrong direction. And our hospital system shared a sense of worry and frustration about our workforce. We had a disengaged workforce that was resistant to process change ideas that they felt were being sort of forced on them. Like no one wants to be process improved, right? Like that, you don't want to be on the wrong end of that verb. But everything needed improving. Our patients were really unhappy with us. Our physician staff were desperately unhappy. And our processes were really inconsistent and and unreliable. And that's a picture of a much younger me on a informational picket line. That was over 20 years ago. So we looked to our friends at Kaiser, which I know, I think of, I'm a California kid, so I think of it as a West Coast thing, but I know they have an important presence here in the Mid-Atlantic region. And with help from them, as well as some help and inspiration from many others, we formed our own labor management partnership with the goals of bringing share staff, but really every caregiver who set foot in the place into the job of improving their work as respected equals, as respected partners, and creating a different kind of culture, one that felt like you got something out of coming to work and interacting with your coworkers. And our UBT program quickly became the centerpiece of our LMP, of our Labor Management Partnership. So UBTs, it stands for Unit-Based Team. This is another idea we ripped off from Kaiser. And we did this for the purpose of improving our culture, making this labor management partnership real at the front line. And this was our best effort to organize kind of a frontline-led, bottom-up social movement for improving the processes that were just so incredibly frustrating to our members. So if there's one thing that I want you to remember, it's this. This is what the point of a UBT is. So UBTs are department-level process improvement teams. Many hospitals in America have some version of a department-level process improvement team. What I think is different about these teams is that they are working on projects to reduce falls, to improve patient experience scores, to improve throughput, to move our discharge times earlier in the day, like all the stuff that you would expect. But that's not what UBTs are for. The purpose of a UBT is not to, sorry about that, not to improve those things. The purpose of a UBT is to change how people feel about coming to work every day. That's what it's for. But the theory of change that animates this whole thing is that the best way to change how somebody feels about their work is to involve them at a deep level in identifying and surfacing the process issues that are driving them the most bananas, and to help them kind of engage with their coworkers in a productive way where they get to go through a process with their coworkers of solving that problem. So these teams are very focused on changing how people feel when they're walking into the building, but we're not doing trust falls, we're not doing pizza parties, we're not doing ropes courses, meditation apps. We're not against that stuff, but we are really focused on the work. So I will breeze through the mechanics of how UBTs work, but I'm happy to address them later. Basically, they're committees that meet, most of them for anywhere between 20 and 45 minutes every other week. They work on 2 or 3 projects at a time. They're standing committees that people kind of sometimes rotate in and out of. But they don't just kind of come together, solve copay collection, and then split, right? They come together, pick a couple of projects that they're most focused on for 100 days. I think we ripped that one off from IHI. And then they move on to something else. So that's how they work, but are they making a difference? There's a lot of different ways to answer that question. And we tailor our answers based on our audience. So this is probably one that's maybe a little bit less interesting to you than our hospital leadership, but we have many hundreds of department quality improvement projects like this, right? I want to emphasize that, and can you see those? Yeah, okay, maybe. We encourage our teams to pick projects that are meaningful, measurable, and manageable, the 3 M's. So we want the frontline staff to pick a project that touches their heart, that like makes them, that they're going to work on this, right? They're going to spend time on it. This isn't just like the homework assignment for the manager to go work on. We want to know that if we fixed this thing, it would like actually make things feel a little bit different for them. We also like for them to measure what they're doing so that they can talk about it with their coworkers, especially in a situation where there's just so much variation. It's really nice to be able to point to those victories. And then finally, we encourage them to pick things that they have some control over. And so these are examples. I would also say, like for this example with University CT, this is a slide that's tailored for the CEO. We reduced their wait times by 20%. We improved their volume by 20%. But what the staff really, really, really loved was that, and the staff's self-reported stress levels dropped by 40%. When we asked them, what is the thing that is most frustrating you at work? They said, like, our patients in the afternoon hate us because we're running an hour and a half late all the time. So it's just like nothing but like griping at us. And like, anybody ever had a CT? It doesn't take this is like a short thing, right? So you go in on your lunch break and you like wait an hour and a half beyond what they told you would do, and then it's like a 5-minute thing sometimes. It's very short. So we really that was a project that they really cared about. I love this quote in particular from one of our frontline managers who was initially hesitant to spend more than a half hour every other week on her UBT, but now says that if she can't imagine spending less than an hour a week on this because it makes the other 39 hours so much more productive. And then we're also increasingly seeing the benefit in our caregiver surveys. So departments that have a UBT in them, these aren't kind of standard across our system. We have around 70 or so across our system at this point that we support. Showed twice the increase in engagement, and interestingly, 4 times an increase in leader index. This is Press-Ganey's, I don't know, hocus pocus mixture of half a dozen questions or so that get at the question of like, what do you think of your boss? So somehow this is having a very dramatic impact on what people think of their leader, of their immediate leader. And then where the UBT advantage was showing up most strongly was in the statement, I am involved in decisions that affect my work, which makes me very happy because agency is very much at the center of this. Yep.
Did it stop working again?
Nope. Trying. Oh, great. Okay, cool. Well, so I will wrap by just sharing a few thoughts on what makes this different. First, these UBTs are co-owned by our labor partners, and we think that the shared ownership of this process really does kind of make it lends some accountability and some legitimacy to a process that I think our frontline staff would probably be somewhat cynical about. Every hospital in America is like a brownfield, right? Like, we are talking about people who've been through 100 change initiatives and seen most of them fail. Like, people in healthcare have come by their cynicism honestly, you know? It's not because like they come out of nursing school cynical or something. And so what we're trying to do with these UBTs is rewire people's brains a little bit through persuading them that they can do this thing that their previous experience has taught them they can't do. And that's a lesson that I have taken from my organizing life, right? Okay, good, thank you.
Cool.
Next up, Amelie.
Thanks.
Nice job.
Hi everyone. So as Randall kindly introduced me, I'm French, and so I'll be speaking about the governance, the shared governance model in French public hospitals, and more specifically coming from the University Hospital of Lyon. I'll be using it as an example of how it was implemented in our hospital and how it was designed to foster trust. So just to begin, a few words on the French healthcare system. It is a very different system from the American healthcare system, and it relies on a universal health insurance coverage, and public hospitals play a very big part in ensuring that all French people have access to care. As you can see on the map, all the little red dots are actually public hospitals, and they are designed, it's on purpose that they are everywhere. It's so to ensure that wherever you are in France, you have access to a public hospital in a certain distance. We also have private hospitals, private for-profit and private non-for-profit hospitals, but most hospitals, the majority of them, are actually public. And that means that when French people think about a hospital, they usually think about a public hospital. That also means that public hospitals are very trusted by the community. They are the place you go when you need care. And they are a big symbol of what we believe, like the generosity of the French healthcare system, meaning that in the national solidarity will provide for you if you need and if you seek care. In that regard, they work a little about like safety net hospital in the US. They have to admit all patients. They use a national pricing system, which means that if you break your arm in Paris or in Strasbourg or in Marseille, wherever you go, the public healthcare insurance system is going to pay the same amount to the hospital. And so then again, it's a very transparent system in that regard. And lastly, as I was saying, like emergency departments are mostly located in public hospitals. Then again, they are the front door of the healthcare system if you need it. So in that regard, the governance of these hospitals are actually perceived as a way to serve public interests and to convey trust from the community and from the employees. What we mean by serving the public interest, it means that two things, that we need to optimize the use of the functioning of our healthcare system. And so for the past, since the early 2000s, I would say, it has two main objectives. First, to make sure that public hospitals work together to deliver the best quality of care to each patient. And second, that we balance budget of hospitals, as it is a publicly funded system. And as in the US, the cost of healthcare keeps rising, it is very important that they don't weigh too much on the public finances. So in 2009, a big reform, the Hospital Patient Health and Territory Act, established the shared governance system that still is in place today in public hospitals. It's a quite complicated system, but it relies on four main bodies: the supervisory board, the executive board, and these are the most strategic in the decision-making process of the daily running of the hospital. And then there are two representative bodies, the medical commission and the social committee, that are designed to make sure that every part of the community of the hospital have a voice in the decision-making process. So these last two are actually consulting bodies. And so the medical commission, every physician, every pharmacist, every biologist, every midwife can vote to elect the members. And the president of this commission has similar powers to a chief medical officer in the US, and also has a big symbolic power because he is elected by his peers. The social committee members are actually union representatives that are elected by the staff, and that's where most of the labor discussions are going to occur in the hospital. And so if you look at it on paper, it looks a very balanced, good balance of powers. But in fact, from the very beginning, this system has been quite criticized because when it was introduced, when the bill was presented by the French president at the time, Nicolas Sarkozy, he said very clearly that what he wanted was for public hospitals to have a boss. And what he meant by a boss, that he meant that he wanted the decision-making process to be more efficient, more quick, and also that the CEO of public hospitals are government appointed. And so he wanted to be able to hold accountable, and that was one of the issues that we discussed today, but to hold accountable the CEO, to implement reform, to implement change, but also to balance the budget. And as you might imagine, this is not always go very well with the rest of the community. So, as I was saying, public hospitals play a big part in the French healthcare system. So any kind of change, any kind of reform, any kind of reform to improve the healthcare system, at some point is going to have some effect on public hospitals. So in 2018, when the new President Macron, announced a new strategy for healthcare, in fact, it had consequences on hospitals, and it had consequences on the governance of hospitals. And he stated, quite to the opposite to the former president, that what he wanted was to put physicians back at the heart of the governance of hospitals. And what that meant is that he wanted to give more power to the bodies, the representative bodies within the hospitals, to have a bigger sway within the decision-making process. In fact, what is interesting for us today, he didn't change the law, the act did not change most of the governance system that was already in place. So we kept the same bodies and we kept the same people in the hospitals. And so the question was, how do you operate such a big shift in the ideology, in the philosophy behind the governance system if you don't change the actual governance system? The second challenge, I would say, is that we have like 1,400 different hospitals in France, and public hospitals in France, and we have only one model. France is a very centralized country, and very often you have one model that you have to implement everywhere. And so if I take the example of my organization, the question is, how do you implement this model into your organization, and how do you operate the shift from how it was run before to how it's supposed to be run today? So first of all, the University Hospital of Lyon is actually a group of hospitals. It's 13 public hospitals. Lyon is a big city in France, and so it's a hospital that have 24,000 staff. And so obviously, when you implement a governance model in such a big system, you have to take into account many different levels of stakeholders. So first, you have to balance between what decisions are going to be made at a central level and what decisions are going to be made at a local hospital level. You have to balance your local partnerships. Then again, as a public hospital, the city, the county, the region is going to look very closely to what's happening within your system. So you have to build partnerships with these people. You have to balance between administrative, clinical, medical, and academic priorities, because it is a university hospital, meaning that we are working very closely with the university. Thanks to the technical changes that the law created, we had a new organization of the medical commission with a new president of that medical commission that wanted to change the organization. And we had we signed a labor agreement with the unions of the hospital, following then again the new power that were given to the representative body, the social committee. So this is the chart of the University Hospital of Lyon. It's actually, I think, the chart that you could have for any French public hospital. But the question is, who are behind these different bodies, and how does that work? So I won't get too much into details because it could be very, very long. But if you look at the different bodies and you see who is a member of what body, then you understand better how it runs on a daily basis. So of course, the CEO still has a lot of power and still has the final cut on most decision-making, most decisions. But the way it's balanced is that you have different actors on the different bodies. So for instance, I was speaking about the local authorities, while the mayor of Lyon is actually the chairman of the supervisory board. And so you have a big vision of what's happening within the hospital system. The president of the medical commission, he's the vice chairman of the executive board. Of course, he's also the chair of the medical commission. Then you have the dean of the medical school that also take part into the executive board, and of course we have university representative in the research committee. Then there is a CNO. I did not speak specifically about the nursing community, but the nursing community is of course very important, and so the CNO, she is a member of the executive board. And these 4 people on the right of the screen, they actually, in addition to all of these different bodies, they have a weekly meeting where they meet every Monday and they share key information to make sure that everybody is on the same page and having the same kind of information they need to inform their communities and make sure that everybody knows what's needing to be done. Then you have the union representatives that have their own, the social committee, their own body. And then you have the patients that also are represented at the highest level at the supervisory board and also at what we call the users committee, which is in fact a patient committee. So that was just the example of how you need to read the chart behind just the chart and just see how it works on a daily basis. But to go further on the creating trust and giving a voice to everyone in the community, basically trying to put into action the call that was given by the president of France. When it came to building the new strategic partnership, the new strategic plan for the next decade of the hospital, the University Hospital of Lyon made a choice that was quite bold, is to reinvent completely the methodology behind it and to create a way to make sure that everybody in the community of the hospital had a voice. So the first, and I would say the easiest way was a survey that was distributed to all employees to explain what the plan was going to be and to have their first basic opinion, I would say. Then they put in place a digital platform, like an online platform, to present each step of the building of that plan. And at each step, then again, people could comment, share ideas, or try to be more involved into the building of the plan. And third, and maybe the most innovative part of this creation of this plan, of this methodology, was the creation of what they call the Agora, which are in fact kind of big meetings that bring together 150 people. And these 150 people are actually 3, I would say, different communities. You have 50 leaders of the hospital, people that are well informed, that know very well the running of the hospital, the bodies of the hospital, medical leaders, nursing leaders, administrative leaders. Then you have 50 people that are coming from outside of the hospital, so member of the, I would say, outside community, so university people, city people, volunteers, patients, people that care about what the hospital is going to become, but are not from the hospital. And then you have 50 people, 50 employees that were randomly selected to then again show that actually building a plan for a decade is an issue that is for everybody and that it's not reserved just for the leadership. So I cannot share a lot about the results about the plan because it is still being constructed and still being discussed. But it's a way to show that when you want to go beyond the words of just what is governance and when you want to show that you trust your community to help you design the future of the hospital, then you can create some kind of a collective, more inclusive vision of what is going to be the hospital of the future, I guess, if we are optimists.
Good afternoon. I know it's getting a little late in the day, so hopefully you are all still with me. I am going to tell you a little bit about 2 related projects at the University of Utah. And just to have a little bit of context, we are in Salt Lake City, Utah, and things are a lot more spread out there. And so our clinical delivery area is about 10% of the geographic area of the United States. So really far. We talk about rural, but we often talk about frontier communities. And so kind of a new, a little bit different than just being rural. I grew up in the Midwest, and you could be rural and still be pretty close to some pretty big things. All right, so one of the things that I find to be very important in this work is just to talk about where are we going. And so why are we leaning into the two projects that I'm going to tell you a little bit about today? But it really is, how do we get back to what do we want medicine to look like? So to me, I really rely heavily on the National Academy of Medicine's Whole Person Health Report, really thinking about whole person, human-centered care. And how do we, that's a big, hairy problem, right? But what are the little things we can do to keep moving us in that direction? And so the work of my office is split into two halves. And today I'm going to be talking about the half that is focused on professional well-being, which is the work of the Resiliency Center. The Resiliency Center was founded in 2017. Some of this work started late 15, early 16, and then became rolled into the Resiliency Center, which is a whole group of people that are hard at work and really designed to create thriving healthcare professionals, systems, and communities. And thinking about what are the specific interventions we can do, and we'll talk about a few of those today, but what does collaboration look like across the organization? Where do we really need to advocate on behalf of healthcare workers? And then how do we evaluate what we're doing and contribute to research? And so when we sat down to work on the Better You project, which I'm going to talk about today, we thought about, well, what frameworks or foundations do we want to rely upon? And we decided to align our vision the way that we approach patient experience within our organization. Now, our patient experience group is very skilled, has a lot of experience, and they make beautiful slides, including this one. But talk about really, what does the patient want? So we know from the patient design studio and others is that patients really want it to be easier for them. They want their healthcare team to know them, and they want their care team to partner with them. And not surprisingly, that's also what patients want, or I'm sorry, our employees want when we're talking about trust within the organization. And so really thinking about how do we create better access to resources and services? How do we make our interactions more than a transaction? How do we focus on the relationships? And then how do we work towards solutions that are proactive and personalized? And so the Better You initiative was to take all of the surveys that we were doing in the employee space and combine them into a single survey. And in our institution, like many, we have about 25,000 employees. There are some that report up through this way, and some that go another way, and some that are kind of related to the first way, but not really, and some who just go through main campus because why not? And so trying to get all of those folks on a single instrument, and then with a single way of knowing within the organization where the hotspots are, and then being able to look at a functional unit. So for example, in the past, physicians would do one survey, nurses and hospitals and clinics would do a separate survey, and there was really no way to look at an intact unit. So if I think about the clinical spaces where I work, we never really could look at the data conclusively together. And so the idea behind this project was that teams and leaders would know what drives professional fulfillment, and then not only knowing, but then has tools to act on that data real time. And then we, of course, wanted to have a measure of organizational success, be able to identify struggling and thriving teams and help get them access to resources. And we really wanted to be able to say, okay, we've got this data on burnout, for example, or on psychological safety, or on intent to leave, but how does that match up with our quality and safety data? How does that match up with our patient experience data? What does that look like for student success? And so we also knew that for that to be successful, that I'm sure that you all are in organizations that have done a lot of surveys. And sometimes you spend all this time and energy getting to a survey, and then everyone has to complain about the data. Well, maybe the people that answered the survey weren't the people that I really cared about, or maybe these people were particularly burnt out, or maybe they weren't burnt out at all. In fact, maybe they were just making it up. So getting to that next step of action of what does matter to you as an employee? What is getting it? You've heard already some examples of these things today, and it's not a surprise we all work together in different ways. But what matters to you as an employee, and what is getting in the way of your everyday work? And so we needed to be able to launch that initial data into a series of what matters to you conversations, or listen, sort, empower, improve conversations. And I will say one of the most important lessons that I've learned as a part of this process is that it is so hard to get from that, okay, I have this survey data, to, all right, now I'm going to have a conversation with my teams. And so laying out sort of what is the process for this, once a year we do a survey, and then immediately the ask is to share the data and have these what matters to you conversations directly with teams. And then for those teams to identify targets to work on at the system and leader level. And then to put that engagement improvement work into the existing committee structures and administrative structures. Don't start a whole new committee to do this work. You already have a committee. Like, let's just get going on this work as a part of all the other work. And then for many years, in 2016, we began a Wellness Champions program that has just this year transitioned into the IHI's Joy in Work model. And we have 3 tiers. One is this foundations course that we run once a year. We ran our new improved facilitator training this year, and we're just about to lean into our Wellbeing Leader revamp this year with the team. But again, how do we give faculty and staff the tools to take this work to the local level? And so important is feedback about what are we doing at the system level to improve the experience of working at an organization. So this feedback loop of, we heard you say you're worried about X, Y, and Z, and this is what we are unable to attack now, and this is what we are able to work on now. And so this is an example of some of the work at the senior leader level that has been taken on in about the last year. And again, getting people within their locus of control. Where's the little thing that we can work on? We're just going to have a conversation about what you did on the weekend, to we're going to tackle parking for clinical workers, which people actually did last year, which is amazing. Again, having a resource for folks to come to work through this. This is a definite work in progress. Each year we are iterating, and lots of lessons learned. I think this project was an example of one where many people across the organization had a very specific idea of what this should look like and who should have ownership over it. And at the beginning of this project, there was not really a person who was in charge. I was kind of like pseudo in charge. And so that made it hard to really come to a decision. And I think I was introduced to a new term yesterday. I was doing some reading, process heavy. It's a lot of discussion. And sometimes the group just wished we could get to a decision. And so it took many hours to build trust within this group and within the organization. And I think in retrospect, accountability and making a decision is also a way that trust can show up and can keep a process moving. With that, I will turn it over to Corey.
Okay, your last entertainment before cocktails, is that what's happening? I clearly had several on the way over. It's great to be with you all and share with you the work that many, including Amy in the room, have been really working on for the last several years. That was inspired by the creation of this law that you heard in my bio, the Dr. Lorna Breen Healthcare Provider Protection Act. Still amazing to me that my sister-in-law, Dr. Lorna Breen, died 5 years ago this past weekend. Probably the most resilient, strong human that I'd met on the planet, and yet was struck down really by the culture of medicine and the operational environment that she was trying to lead at the emergency department at the New York Presbyterian Allen Hospital right at the peak of the pandemic in April of 2020. We got a call from our senator, U.S. Senator Tim Kaine. Jennifer was Lorna's little sister. I was the third wheel in the relationship, but I was the husband who was a healthcare leader at the time. And when Senator Kaine called, he said, I see a ton of parallels between the experience that your sister-in-law, Lorna, had, as well as other healthcare workers, and what my son's experiencing in the U.S. military right now. And he said, I assume that there are supports in healthcare like there are in the military. After laughing several minutes and him stopping me, no, I'm kidding. I just said, no, sir, respectfully, that's not the state of affairs in healthcare. I think healthcare is actually behind the military in this concept. And so they went off and they called us about a month later after speaking with national experts and said, we want to create a new federal law and actually name it after Lorna. And at the time, it was an incredible honor. I didn't realize I'd be spending a lot of time in Washington as we're trying to extend that law now. But this happened in a very, very rapid pace. Most federal law takes somewhere between 8 and 10 years to be created. This was done in about 2 years, almost start to finish. And I point to a couple things. One is when Senator King called us and the original designs of this law were put in place, pandemic hadn't even barely hit most places in the United States. This was not a pandemic law. This was really pointing to the pre-pandemic state of affairs for health workers. So I think that's an important context, because when you see what the Lorna Breen Act did, it was not trying to redesign the entire U.S. healthcare system. It was starting to build a staircase of health policy supporting the well-being of health workers. And that's so what it really primarily created were 2 streams of programs. One that was co-led by the team here at GW, my friend Randall down here, and IHI under the Workplace Change Collaborative. There were 45 grantees from HRSA that were really focusing on this work at the local level. It's a national pilot group if you think about it. Understanding that there's about 6,000 hospitals in the country, we had about 45 that began that work. Amy was one of the recipients as well at University of Utah, which is how I came to know her. The second group of work, which was a much smaller piece of the work, will interest you in that it's a leadership-based change platform called the Impact Wellbeing Guide. And interestingly, when that was envisioned, it was money that was allocated to the CDC and their occupational safety arm, NIOSH. It was envisioned as 2 campaigns, a campaign focused first on healthcare workers, and then a campaign focused on healthcare leaders. And I've never participated in the creation of a national campaign, so this was news to me. But the very first thing you do is you ask the people who you're trying to communicate with what the problem is. And after speaking to about 1,000 healthcare workers, they kept pointing to the leaders as the problem. And they said, stop asking us to be more resilient. That's a 4-letter word now for us. Stop giving us yoga and meditation apps. You need to help them redesign this coal mine. Stop asking the canaries to be more resilient and strong. And so we restructured that campaign to be one campaign focused on healthcare leaders and giving them the 6 steps, which we'll talk about in a minute. Between both of these campaigns, we've learned very similar things. And before I started, let me just say this is 3 years of work condensed to 4 bullets here. So yeah, super high level. But it's interesting to me, these themes keep coming up. Create a center of work in these well-being initiatives, and don't just rush into creating it. Ask the workforce first what the problems are. This time last year, I was at the World Health Organization when we were still members of that. Too soon? Anyway. And it was interesting because there was a gentleman, he had very fancy shoes. He was from Amsterdam, and I'm from the University of Virginia, so I noticed them because they were orange and blue, the UVA colors. But he said, I think this is a one-size-fits-none issue. And I thought, okay, maybe, but we need to ask. We need to ask, because I think there are some themes here. And really, the next bullet is shift the onus from this being an individual problem to an organizational one. Now, I will tell you, doing this work at the foundation level for the last 5 years, the lion's share of responses to the workforce during the pandemic has not been to do what Amy and others have done, which is take this organizational approach. It has mostly been giving out EAP phone numbers and those sorts of things. Because remember, most healthcare is delivered in community settings and not in large academic centers that are advancing this work. And so that shift actually has not happened yet across the country and really needs to. This culture of well-being is critical. As we all know, healthcare has been so designed to be a culture where we're talking about the patient, the patient, the patient, the patient. We need to be thinking about the impact of the work on the workforce, and the way you do that is to make it okay for the workforce to speak up, to create that culture of safety, all the things we're talking about today. And then, empower those closest to the problem. We know this intuitively. We've made great progress, interestingly, I think, in the quality areas, putting these great infrastructures into hospitals across the way. But we rarely tap that same infrastructure just to ask the workforce how that redesigned process is going to impact them, as an example. So the Workplace Change Collaborative came together. Randall and others helped to lead that work. And of the 45 grantees, they represented about 24 states. And they made, the group, by and large, made great success, really looking at organizational change, making sure that people knew the programs. I got to tell you, folks, I have never, I spend a lot of time connecting dots between a lot of different macro level concepts. There are so many people who call me from a large health system, and they say to me, I'm interested in this well-being stuff. And I say, did you know you have a well-being office? Because I know their number. And they go, what? So just making it aware. This is a new thing. The publicity is really, really important. And then making sure that the participants are engaged with enthusiasm and really can be particularly participatory. That's a hard one to do, in the improvement process. They've been huge. So a few numbers, and I actually was just on Capitol Hill reciting these numbers this morning to policymakers to try to extend this law for another 5 years because it has expired. 86% of the grantees instituted well-being programs, 70% provided peer support and crisis support, 55% offered mental health services, 34% redesigned workloads and workflows, critically important. Some of these next numbers in bold are ones that particularly were notable this morning meeting with policymakers. Some organizations reduced burnout up to 37%, turnover 35%, anxiety 53%, and 50% on depression. Those are huge numbers, and while by and large not all the organizations accomplish that, these are some of their experiences. These are the kind of things that when we talk about the importance of continuing the work and the need to do this at the local level, this is what's possible. This weekend we were in the Wall Street Journal, they did an article about the increased rate of suicide among residents in the United States. And one of the quotes that I thought was really notable came from the current president of the AMA, who noted that there is a 5 times increase in the rate of depression during the first year of residency as compared to when a physician was a medical student. So when you think about that increase, and then when organizations do this work, they can then decrease depression by 50%. It's hugely impactful and critically important. This is the Impact Wellbeing Program. I'll zip through this very quickly to help us get back on time. But this is that campaign materials that we created. We tested it in a large 8-state hospital. I think it's an 8-state hospital system across the country. And it's really meant to walk healthcare leaders through what I like to refer to as the building blocks of creating professional well-being in their organization, really thinking about it from that systems level perspective. All of these materials are online and they are all free to all of your organizations. I just need to put a plug in for that. In addition to that, our foundation, in partnering with our national coalition, which we call All In Wellbeing First for Healthcare, which has over 30 healthcare associations and others, we've taken this material and we've turned it into a technical assistance program, and we're taking cohorts of states, of hospitals. We're in Virginia, North Carolina, New Jersey. 2 days ago, we announced Wisconsin as the next state, where they're coming together and doing this work together as they all march through the Impact Wellbeing Guide contents. And so there are 6 phases of work in the Impact Wellbeing Guide. And note that the very first thing is to do that organizational assessment. You probably can't read this, that's too far, but you can download the materials. Do that organizational assessment work, and then develop, wait for it, an interdisciplinary team at the very beginning. This is not just medicine's problem or nursing's problem or pharmacy's problem. This is everyone's problem, and so we need to come together collectively to address it. And building that team from the very beginning to address it is critically important. And organizations like the University of Utah have really shown that that is a model that can work for many, many other organizations. I'll just point out one more thing as I go. This is also the opportunity for you to send a message to a member of Congress if you want to do that. The law expired at the end of the last Congress. We were expected to be, and we were included. I say we. It's just my mom thinks I got $150 million. So she's really proud of her son. I'm like, nah, didn't happen, Mom, but that's okay. We have this law expired at the end of the last Congress, and the law was included in the year-end continuing resolution that many of you may have seen was blown up by a few tweets on Elon Musk, which was unfortunate. And so we're back to to restarting this work. The law has been reintroduced in the House and the Senate, has great bipartisan support. This has not been a political thing, but it has an opportunity now to be extended for 5 years at a rate of $45 million a year, which will increase the pool and the impact significantly. So last Congress, we had over 17,000 messages, many of them custom, just using the same little QR code. I will also point out that one of the things that will be different this time around in the grants is that the grants will prioritize getting at the root cause of much of this work, which is that administrative burden that is on the shoulders of healthcare workers. Not exclusively, but certainly one of the things that they wanted to focus this round of grants on, assuming we can get it all done. That's me. That's the Lorna Breen Foundation. If you have any questions in the Lorna Breen Act, in a nutshell, if you all have any questions or want to contact me, please feel free. We're doing this work each and every day on behalf of all health workers in the United States. Thank you so much.
Thank you to all of our panelists for your wonderful presentations. I have a few questions here, but I hope that people will come up to the mic and ask their questions as well. One of the things that I noticed as you all were giving your presentations was around employee voice, psychological safety came up multiple times. So can you all speak to the role of psychological safety in creating spaces that are really enabling trust and difficult conversations? Can be for anybody. Yeah.
One of the things that I think has been incredibly useful as a part of the survey process is measuring psychological safety, because then you can tell a group, hey, your psychological safety is really low. You probably need to think about approaching the group in a different way than if it's really high. So if it's really high, people could just go in and have a conversation. But if it's really low, we've definitely had some leaders who say, well, it's psychologically safe because I say it's psychologically safe, or it should be psychologically safe. And so really great article in the Harvard Business Review this month by Amy Edmondson and another writer, talking about the more you talk about psychological safety, the harder it is to have it sometimes. But like focusing on candor and trust might be a better, in reflecting on this conversation, adding that trust piece. But so for example, in those groups, having either a facilitated conversation or an anonymous way for people to put in comments. So for example, we've had a couple groups use Poll Everywhere, which has been a nice way, because then other people can vote it up and down, and it doesn't feel like maybe as sensitive. I'd be curious what others are doing.
So it's really interesting that the Slow Talk platform really addresses these issues, because I'm sure you've all said it yourself. I'm not sure if it's okay for me to share what I really think because of the repercussions. And we all know, we've all experienced that, and how, the invitation often results in betrayal because you think that you're going to share something that will be received and it's not. So the beauty of the Slow Talk platform is everybody has the same question. And there's research to suggest that the audio-only component of it actually enhances empathic connection, because we're not worried like we are on Zoom about, how we look and that kind of performative part of it. We can actually be more authentic. It's also designed to not be actually done in front of a screen. It's really designed to be done from anywhere. So if you think about where we feel comfortable, we can engage in this conversation with 5 to 7 other people, like we were having a kind of focus group. And there's also the facilitated part of that. So the extroverts among us can have some guardrails, and we can get private cues that maybe you need to make space for someone else. Then what happens that I think is really important in this process is the analysis is shared with, in this case, it would be the leader, but it's also shared with the people who participated. So they can see their voices, they can hear their comments, anonymized. So it's not like they're attributed to me, but they're represented there. My words are there. And then that, I think, helps people feel more confident that I'm being heard. And then there's the loop that I hear you, and the invitation for further dialogue about a particular issue. In this case, it was about relational integrity, which is very much related to trust. You know, can we be whole in the context of our relationships with others? Can we feel as if we're included and our voices actually honored?
Yeah, thanks for that, Cinda. And that kind of brings up another question I had around communicating the different efforts that you all talked about. So like, what are the feedback loops that you have in your different efforts to try to communicate what's happening, that you've been heard, and here's what we're trying to do about it?
A couple of different things. I mean, going back to psychological safety, one of the things that we don't use the phrase psychological safety, but all the time we talk about UBTs as an instrument for making it easier to talk about hard things. And I think that the two-way accountability that is built into the labor management partnership model, where leaders are, even frontline leaders, are accountable to the staff to do some things. Like, everyone kind of agrees at the end of a meeting. It's a good meeting, right? Like, we have good meeting hygiene, where you leave the meeting knowing what everyone's homework is and what when you're going to meet next and what's going to happen. And so you're really, we are trying hard to clarify expectations about what's happening. On communication, I would also say we give our frontline leaders lots and lots and lots of opportunities to share out like their favorite projects with the wider community. So we had we have 2 more coming in a couple of weeks, but we had a UBT fair last week that is basically like a science fair, where we had over 700 people attend this lunchtime event with 31 different posters. We asked a bunch of our frontliners to make a poster. We helped them do it, kind of telling the universe about their favorite project. And these fairs are really fun. We write spoofy lyrics to pop songs and pass them out, and have several hundred people sing kind of a spoofy song about how much they love process improvement. And Don't Stop UBTing was last. Don't Stop UBTing. Don't forget to measure those feelings. Projects and meetings. Oh was the chorus. So so we're trying to sort of give people lots of different channels to communicate how they're doing.
Thanks for that, Will. Amy, I know that you also incorporated feedback loops in your work. Can you speak a little to that?
It's definitely a work in progress. I would say our nursing unit has done the most amazing work in this space, supported by our patient experience folks. And so they've basically done a Listen, Sort, Empower, Improve project with 6,000 people, where every single unit has their own board. They meet in huddles with a very regular basis. And then things get pinned if they're beyond the control of the local group, and they can be entered in an app, or they go on the board, and then that can get reported back to the unit to say, this is what we're working on, at a bigger system level. And I will say, we do have a poster session, and it is not quite as fun. So we had 60 posters. It was sing. Last week, but there was no singing and no lunch. So that's learning right there.
Thank you, Amy. And Polly seems to have a question.
I have a question. So the French experience, where there is a structure that is predefined, that is then sort of handed down to each of the regions. And it mandates the participation, a sort of heightened role of what here we would call a medical committee, which is an expanded committee. It's not just physicians. And then, interestingly, the labor unions in a different category. So over and beyond whether that's the right structure for us, what do the panelists that are not Amelie think about whether that would be helpful or not? Or, you know, to have some kind of governance structure that is either part of a certificate, you know, an accreditation process, or part of a pay for performance thing, or maybe even mandated. So regardless of like the degree of imposition of the model and how it's done, would it be helpful to have outside guidance on how to create shared governance, presumably as a way to strengthen these programs that are happening within organizations, or not? And if it is helpful, like how would you envision it in this country?
Wow, that's a big question. So, in theory, I think having the structure seems like it would be an enabling factor. The big question is how. Because if it's not designed in a trustworthy way, what we see about anything that's mandated is resistance and resentment. And so it could have the exact opposite. It could intensify the cynicism about, you know, is my voice really heard? I think the design would be really key. You know, how do you create a mechanism within this structure where people feel heard, where people can see actions that come from their feedback, where the communication has clear expectations and people can see that their expertise is actually appreciated and honored and taken into consideration. So in a way, the devil's in the details. And what I worry about is the top-down imposition of that already seems to have a lot of resentment associated with it. I think it would be a hard sell in some quarters that would be a solution right now.
I would take it, but I'll take two. But I guess I'm probably guilty of being really, really microsystem focused. That's where we have seen, I think, the bulk of our effort kind of pay off. And so I think in my mind, the purpose of a big governance structure would be to enable more of that frontline focused microsystem work. Like I loved the thing that the point that I think it was Lindsay who made it in the last panel, that for most frontline staff, trust in the organization is about trust in your immediate supervisor and your coworkers. I was just in a conversation yesterday afternoon with a big group of nursing assistants from a single hospital from all different floors, and they were comparing, the conversation they were having was about like, on which floors can you expect lifting help to come if you call for lifting help? Like you hear the lifting help call go out over the loudspeaker. Some of the floors people show up and some of the floors people don't. That's within one system, right? Same CNO, same governance structure, same most everything. The managers are different and the cultures are different. And so we got really focused on like what are the process enablers that could like help us kind of standardize a set of behaviors that would enable them to trust each other more.
Can I jump in here just for a second? So on March 18th, by the way, that was the day that Warner Breen Act was signed. We've now worked to make that National Health Workforce Wellbeing Day. And so on March 18th, the last 2 years, we've had an event with Johns Hopkins University at the Bloomberg Center just down the road. Polly, you were there. I don't know if you heard, one of the keynote was Michael Bush. He's the CEO of Great Places to Work. He said a few things that I think are important to this conversation. One is there are not a lot of hospitals that are great places to work. Mm-hmm. It's a third of the economy, and there are not a lot of hospitals on my list. Second thing he said is that frontline leaders often are the most important when it comes to the well-being of the workforce. And I think about your question in the context of that day-to-day experience and Will's answer and Cinda's answer. I think we have a big gap in how we're training those for frontline leaders, what their expectations are, how that gets reported up. Most healthcare is like a lot of things, right? You promote the clinician who is a great clinician and you don't ever train them, and then we're surprised that it doesn't work out well because they don't know how to do their job. And I get calls all the time from nurses who say things like, Corey, my frontline nurse leader, she just, she talks about my burnout. She keeps giving me the EAP phone number and this app, but what I need her to do is I need her to listen to my day-to-day experience, but she just doesn't, there's not the psychological safety parts, and she also just has no skill in this. And so I think, there's a million ways to try to skin this, but I think one of the critical ones is to look at the frontline leaders, how we're training frontline leaders, how we're holding them accountable so that they have the skills. Because as you just said, Will, that's where the experience is. That's when you fire your boss. It's not like you don't usually fire like a person who's all the way at the top of the organization when you decide to leave. So I think we probably get further with that kind of a thing.
I really agree with you. Part of the reason at the University of Maryland is if you think about the span of control in nursing for a unit manager, some of them have hundreds of direct reports. How can you possibly know everyone and be available and responsive?
Right.
And to your point, if you haven't had the skills and you yourself don't feel heard, if you're advocating for your direct reports and you don't see that there's action on that feedback, it just reinforces this whole, cycle of disempowerment. And so how do we create systems where that middle manager, who honestly has the worst job, they get pressure from above, they get pressure from below, and they're supposed to have all the answers. They feel isolated, they feel like no one's listening to them. And so that really is an important leverage point to invest in those middle managers who have the most influence on a person's experience at work. There's data that is the most important factor to determine whether a person stays in their job. So maybe that's the place.
That example that I shared within our nursing org, that shared governance project was all about getting magnet status. And so that kind of interest in being recognized was a really strong motivator for that team, which is now doing a lot of that training in the mid-level managers. Rather than someone saying you have to, it was people wanting to, which I think does really change potentially how you would engage.
Maybe just if I can comment on the French system, I agree with what has been said, that it can be just words, it can be just a structure, but it also can be that it's the bare minimum, and then you have to build on it. And so the same system can work or not work among the, then again, hundreds of French hospitals. And so it creates like the bare minimum of accountability, and then you build on it to give it more sense in your organization, and you add to it the trust part of psychological safety and these different aspects. But the fact that there is a minimum, I would say, from my point of view, seems to be quite, it makes it simpler. Like if you go to any organization, if you change your organization, you know that you're going to find this as a minimum. And also you were speaking about creating space to have psychological safety. The social committee, I would not call it a psychological safety place, but the fact that in all French hospitals there are union representatives, for instance, that also creates some kind of spaces, formal spaces that at least exist for people to have their voices heard. So the French system, as very often in my opinion, is very formal, but if you go beyond the word and you put sense into it, then it can be adapted to each organization and it can make sense.
I love that. Yeah, that's exact. I mean, our UBT program would not exist. We would not be getting the results that we're getting if we didn't have the formal, the labor management partnership, right? Like we have language in the contract that says workers can't innovate themselves out of a job, right? There are a number of formal mechanisms that like actually help you contractually create psychological safety and all the rest of it. Yeah, exactly.
Thanks so much. And I think we have a question from the audience.
Hi, thanks everyone for your remarks and comments. I'm Rick Burzon. I teach in the School of Public Health. This question is for Will, although Hannah, you may also want to jump in on this. The constituents that you represent in your union are important constituents of the healthcare system, but you don't include the clinical care providers in the folks that you represent, the physicians, the physician assistants, the nurse practitioners. If you really wanted to exert some pressure on the system, how would you include those groups in the folks that you represent so that you could actually make some changes in the system, as an example, ensuring that healthcare providers like physicians and PAs and NPs can spend more time with their patients and don't have to see a patient by mandate every 15 minutes. Maybe they could negotiate for 30-minute segments or something. In order to do that, though, you would need to involve everybody in that kind of pressure if you wanted to do a strike. Is that something that you've thought about, or that you could do, or that you might think about including these other folks that are not part of the constituents that you represent?
I have a couple of imperfect answers to that question, but let me give it a shot. So one, our UBTs do include a number of providers. So even though, but it's kind of representatives from the providers. So it's not. I don't want to claim that we're changing providers' experience, day-to-day providers' experience at a deep level through our UBTs, but most of our UBTs have one or two providers who are involved in kind of representing their group in the decision making around the things that the UBTs are working on. But the other thing I would say is that the union, the share union which is affiliated with AFSCME, the share union, which is the union in our partnership, just recently organized the attendings at Cambridge Health Alliance, which is a different hospital than is in the partnership. But the reason the attendings chose to organize with the share union was because they were really interested in this UBT model. So I think they are interested in organizing around non-economic and non-kind of traditional issues.
Right, but you didn't really answer the question. If you silo the constituents that you represent, you're going to have a lot less power to actually make changes in the system than if you included everyone that is involved in the healthcare system. Not just the folks that push the gurneys and assist the nurses, but I mean the real power is in the people that provide the care. Is that something that could be done? You've organized these other groups. Are the physicians organized? Are the providers organized in some other union somewhere?
Not at UMass Memorial, no.
Can you work with the medical committee?
We have been working, there's a lot more that we could be doing to work with the medical staff. I think our focus, because of the sponsorship and just the way our partnership works, the focus has been on improving the experience of the members of the union, the folks who are making $35,000 a year, but they know and we know that we're not going to be able to make significant changes without including other constituencies as well. So I know that's kind of an unsatisfying answer,
Well, I think
would
it
it work
could be
better
done.
if we had one big union and everyone organized?
Right, I'm not
and
talking
working
about
together?
the Wobblies here. I'm just talking about, expanding the number of people that you represent to really be able to have some power to make some changes in a defective system that has been this way forever. That's all.
Yeah.
So I think we are at time, but I really just want to thank our panelists for all of your presentations and for this great conversation. And I will pass it over to, I think, Polly and Gwen for closing remarks.
Does this work? Yes, I'll pass it along. So first of all, just thank you all for being here and contributing to this summit. I think, the hope was in these final few minutes that we could reflect on some of the emerging themes and sort of synthesize them in a way that we could then both contribute to this publication that we want to do that will come out of the summit, as we mentioned, but also think about the messaging for groups that are not here. In particular, some of the large organizations that have a lot of power in the healthcare system, like the American Hospital Association and the AMA and the ANA and so on. Because really this issue should not be in the ivory tower. These issues should be in the healthcare organizations that represent healthcare workers. But as I think you've sort of witnessed here, this is a beast to get our head around. And I think a lot of people have been working on burnout, a lot of people have been working on moral injury and wellness, and increasingly there's a recognition that this issue of clinician trust and health worker trust more broadly in organizations is kind of as difficult as it is to get our head around the whole. There is something about this that is the crux of the matter. It is at the core. And so I know that IHI is working on guidance. I know that there are academics in different universities that are working on this issue, but the thought was that via this summit we would be able to sort of envision a framework that would allow us to communicate more broadly about the importance of doing more work in this space. And I'm eager to hear from my collaborators about their takeaways as well, but I guess my main thought is that, I don't know whether concentric circles is the right kind of visual, but a lot of the really creative work is happening, as Will said, at the micro level. I think that the work sort of in the middle, which is more around perhaps, shared governance and committees and even unionization would be kind of the meso level. And then there's all the policy work. And the thing about the policy work is that it touches on so many different areas of law and regulation and accreditation and payment incentives that it's just a world in and of itself. But I think it seems to me that the next step is to sort of create these levels more explicitly and have people working on each of these levels in ways that allow us to sort of begin to, if not derive lessons learned, then at least be able to say, here's 6 experiences that are trying to do this. And this is, these are the people you can talk to about it. And if you're a researcher, maybe you can partner with them and study them and set up some kind of comparative analysis of the different approaches within each level. Because, as I said at the end of the first panel, I do have the sense, and this is just me, others may have other opinions, that we actually need to work at all those levels in order to make any headway. And it's not, and often we've sort of been afraid of mixing with people who are at another level because we tend to, look down on each other. And so bringing together people working at the 3 levels, I think, is one of the things that's been unique about the summit, as well as the different disciplinary perspectives. And I do think, I think we just can't solve these problems at one level, is I guess the hypothesis. So my thought would be that as we do the set of papers that we want to do for the special issue of the Hastings Center report, that we'll try to, in some kind of introductory piece or some kind of summary piece, try to place each of these stories in a framework, in collaboration with those of you who've told those stories, because obviously that's your choice to see if you feel that that's where your work belongs. But it's not a question of one initiative being better than another, at least at this stage. It's just understanding how different approaches can sort of get at this beast. And the remaining sort of area where I particularly feel some frustration is that we, all of the forces which you brought up of a profit-driven healthcare system that are determining the way leaders behave and the way health workers have to conform and in their practices are, that major driver, it's like nobody really knows how to get at that. We kind of acknowledge it is the core problem, but we don't really have any ideas about, and so we sort of dance around it. And I think just to say that, I get that's where we are, and we just sort of acknowledge that we're dancing around it. And if there are ways at a policy level to begin to work on it. I mean, I think there is, legislation that's being debated, at least before the elections. When Bernie Sanders was the head of the Health Committee, they were talking about how to do more regulation of private equity in healthcare. There's, efforts to look at, the right to organize. There are all kinds of legislative efforts, but they're not going to, any one of them, be a silver bullet, for this huge issue. So anyway, I don't know whether that's a depressing thought or just a reality check, but I do think that we're going to continue to plug away at trying to create a framework to understand the vast sort of the differences in the types of healthcare workers. Also, I think it was really interesting and important to think about how frontline direct care workers tend to think less about maybe some of these macro forces than perhaps clinicians who are bumping up against it every day. And so the experience of the distrust is not the same for everyone. It depends on where you sit. And so having targeted kinds of interventions for different groups really makes sense. So those are my initial thoughts, and I'll pass it on to Gwen.
Thank you. I just want to say what a pleasure it's been to be with you guys today. This represents the small planning group that brought together so many incredible experts, and thank you for all of your contributions on the panel. I think going from the idea stage to this meeting today has been so exciting to see, as you mentioned, that this is really, we've talked about so many different topics, and yet there is one common thread. And there are, any number of problems that we can lament, but what I found most encouraging as I was going through the literature in preparation is that so many of these topics and so many of these proposed interventions, although, we talked about reinvesting in Lorna Breen Act, et cetera, there are things you can put money behind, but a lot of this doesn't require major investment, right? The theme of the last panel for me was that individuals have the power to make incredible change, that they have the power to do so from wherever they are, whether they're earning $35,000 a year or they're the CEO of the organization, and touching many different hospitals and health systems. And we can lament, values conflicts generated by profit, but as I mentioned, that's one part of the story, and there's something much deeper that we've touched on here. And my bias is always to action. We can talk about policy change. We have laws against the corporate practice of medicine in 34 states in the country. The problem is not that this is not illegal. The problem is that there's no enforcement. And so it's on each of us, I think, to drive enforcement, to create change where we are, to bring others along to understand that if trust doesn't sing to them, as we've framed it before, for others, there's a lot of different ways to talk about this, that talk about this very core issue and the many ways that it's experienced for all of us in this room, whether you're a nurse or a physician or an organizational leader or a labor leader. And so I find this gathering very inspiring. That's the note that that I'm taking away, and just really excited to continue the conversation with all of you, to take this very perhaps fluffy or esoteric topic, is how I viewed trust at the beginning. I've studied science and chemistry and math, and I don't know how I ended up here talking about trust. But I'm eager to take others on that journey with me. And I hope that's what we'll do in the publication, and I hope that's what we'll do in the next stage that follows. Thank you.
Thanks, Gwen. Gosh, I'm still very much in my stew here. I mean, I think what is both really just kind of sad is that what brought us here together is how hard people find their jobs. And I think that just knowing that and saying it and continuing to say that people are experiencing real pain at work at a variety of levels, and how, I mean, not even unethical it is, but just how hard it makes it to live a good life when you hate your job. And that's such a common experience and people can really wrap their heads around it. And so I think, as, again, just sort of sad as that is to acknowledge and say, it's important to recognize as maybe a shared starting point for the summit and for the report is this is a real human problem that we understand. And it's part of our theory of change that trust is important in every context of life, but especially to have a professional identity and meaningful work life, that you trust your colleagues, that you feel like your organization has your back, and that policies at a variety of levels produce that. And so I think that's part that can, that the framework comes from sort of we've created this problem. Everything has melded together to create a direct care worker who's sitting there for 12 hours and can't pay, has created this problem of the resident who's working 85 hours and making medical errors. We've created it, and which means we can also create something different, is the sort of inspirational, happy place to land. I feel uncertain still that trust is concrete enough. I don't know, on one hand, it's really intuitive, but because the things that have melded together to produce these situations depend on such different kinds of relationships with colleagues, relationships with professional organizations, relationships with managers, relationships with CEOs, with senators, and all of these things. They're all different kinds of relationships, and trust may look different in each one of them, or at least trust should, I think, look differently, and or the behaviors that create trust look differently in each of those. And so having one word is sort of confusing, because how a CEO, what makes a CEO trustworthy is very different than maybe what makes your direct manager behave in a trustworthy way, which is very different than a bank, for example. And so defining in those various relationships what trustworthiness and therefore a sort of trusting relationship is also seems to be part of the task. That yes, there's a very intuitive sense that trust is what we're aiming for, but acknowledging how different that will be required to be enacted. And then of course, and then, I feel as dismayed as you about the whole financial incentive problem, but that being able to, well, actually, I don't know what to say about that, other than acknowledging it and showing how difficult that makes it to trust, when we know that the goal is not, that people with that goal are not trustworthy actors, which kind of puts pressure back on the relationships that you can actually change. And I think it's just the second panel is just an incredible body of work of people who are making real difference, real change to make people's lives better, which is ultimately why we're all here. So thank you to that panel for, mainly for the work, but definitely for sharing it. I don't know, should we open it up or is that too risky?
If the panelists, anybody have any thoughts about where you all want to see this go? And anyone, but particularly the panelists, since you all will be writing papers. Yeah, do you want to use the microphone just for the folks online?
So one of the things we didn't talk about, and is sort of sub rosa in our conversation here, is we've talked about trust, and trust has actually been broken. And so in order for us to heal from that broken trust, we have to name that what is true. And that's where we've spent an awful lot of our time, is naming where trust has been broken. So the second part of that equation is, what is the process and what is necessary to heal that broken trust? And, you know, part of it is and this has been really true after COVID, it's like, okay, the pandemic's over. Now we need to get back to work and move on. The problem is, it's another layer of broken trust, because people have not felt their experience has actually been acknowledged, that it has been appreciated what it took for clinicians to show up day after day after day. And so a process of healing from broken trust is also part of this puzzle. You know, that there are times when amends need to be made, where people have to take responsibility for how they have created the conditions for broken trust. And that's a whole other piece of the puzzle that needs to be part of this initiative, is how to help leaders, help when we have had broken trust among us as team members. How do we recover from that? How do we restore our sense of relational integrity when it's been compromised?
I immediately think of like a reparations process almost. That was my first thought, is like, oh, you need reparations, and that's not, it may not be, probably is not financial reparations. It's a process of repairing what was broken. Yeah, that's part of it.
I love the idea of the mapping work, of mapping what we do know, and starting with who we do know. And of course, there's going to be many people outside this room that are doing this work that we don't yet know, all over the world, and kind of creating an open platform to capture or catch people, to acknowledge the work that they're doing somewhere, somehow, to be a part of a field of practitioners who care about this work, and to think about, I'd love to invite everybody to have some way of bringing back to ourselves together. There's so many unanswered questions that we raised here today that are really important. And again, there may be others that are tackling them, that we want to ferret out and bring into the tent. And there may also be those among us that want to address them, or want to say, like, I have my hand up, I really want to look at that particular relationship, or how power plays a role in this area of trust, so that we can collectively advance the field. And then there's sort of, what actions do we continue to take in the work that we're learning from? So feeding back that learning loop to ourselves and others around the learning. And then what actions do we actually need some collaborative work on? Like, is there something that we see collectively in doing this around moving together around, like, policy, or around standard practice that we want to bring to health systems, because we know it's generating better patient care, better workforce satisfaction, better retention, et cetera. So those are the things that this leaves me, like, just from a concrete standpoint, asking, and in a very invitational manner. Thanks.
Excellent.
I want to thank you, Polly, and your team for putting this together. No one has said this, but I think it probably needs to be said, which is that things are going to get so much worse now that half of the CDC is gone and people will not be informed on a whole variety of health-related issues, and that we have someone leading HHS who is a vaccine denier, which will just make people who should be vaccinated question whether or not they should be vaccinated. So I don't know how you might want to incorporate that, or if you want to incorporate that into this special issue. But it's so obvious that it probably needs at least a footnote.
Absolutely agree, and it also is obviously impacting the health workers' well-being themselves, for sure. Thank you for that. Well, I think we have come to our conclusion. I really want to thank all of the people who spoke today, as well as those who provided their expertise and advice in the Planning Committee, and especially to our partners at Hastings and our sponsor from ABIM Foundation and HRSA, and Peter and Jeff, if you're out there, thank you very much. And we will be in touch with many of you to continue this work. Thank you.